So for tonight, we're going to finish up Joe's lecture on critical thinking. There's only a few slides left on this, and then we're going over EMS operations tonight. Operations tonight, it's basically just covering everything about the ambulance, from different types of ambulances, what's inside the ambulance, appropriate driving, appropriate responses, taking care of a patient in the ambulance, that kind of stuff. So a little better than dull pharmacology. Tonight, we're going to get through this. Did he already hit record?
He already did, yes.
He did? Okay. Take your guys' word for it.
He says I don't take no word for that.
I don't know, you might have to re-record it again.
I don't know.
He definitely said he was recording.
Yeah.
I've been playing with you, I don't know.
Yeah, pretty much. Alright, so tonight we'll start with critical thinking, decision making. So this is really just about forming a field diagnosis, knowing, I have a sick patient in front of me, what am I thinking is going on with them, and how am I going to fix it? So that's kind of a big part of our job. So EMT diagnosis and critical thinking. Diagnosis is labeled for a condition, so what pathophysiology process are we believing that's going on inside of them? Is it asthma attack, anaphylaxis, whatever signs and symptoms you're seeing. So we come up with these diagnoses based on their history, physical examination, what we find, vital signs, presentation. Like you can form a fairly good general impression just initially right off the bat to rule out, is this ankle pain, is this abdominal pain, is this chest pain, right? So it involves both physical and intellectual activity. A lot of experience comes into this, thank you. So how a clinician reaches a diagnosis. Clinicians have different levels of training, experience, time, technology, other resources available to you. Techniques vary among types of clinicians, so how I approach a patient, how I ask questions, how I assess them may be different than how Derek or Joe does it. You develop your own system that works for you, and that's the big thing. Once you guys really start getting thrown into the field, you're going to come up with your own method that works for you. There's no one set method to this. The big thing I'll say with this, being professional, being confident in yourself, know that once you get your license, you've done everything required to reach your license at that point, know that you know the material. So, the traditional approach to reaching a diagnosis, interviewing a patient if you can, if they're unconscious, obviously that's a little different. Interviewing them in a controlled environment, so we're never in a controlled environment. We're out on a scene somewhere, whether it's on the side of a highway, out in the middle of the woods, or in somebody's house. We're not in an ER setting, we're not in our own room, we're not at a doctor's office. So we have to take that moment and control the situation ourselves. If that means I've got bystanders on scene that are creating an issue, do what you got to do to control the scene so you can come up with your best diagnosis. So the traditional approach, assessing the patient obviously, getting a set of vitals on the patient, doing a proper assessment that may include a set of vitals, a glucose, 12-lead EKG, asking the patient about their symptoms, going based on their past medical history that can lead you to what's going on. Then you come up with a list of conditions that work towards what you're finding. So we come up with our field diagnosis. It's not an official diagnosis, but our field diagnosis is just a working of what we believe is happening. Do we think they're having a heart attack? Do we think they're having an aortic aneurysm, a PE, that kind of stuff? With that, we don't want to become narrow-visioned. So this happens to all of us. With our experience, we've dealt with the same situation multiple times, and it's always been this. And we forget about other things going on. That's kind of a big thing I can preach to you, is don't develop that narrow vision. Always keep an open view that other things could be happening. So that's where we come up with our differential diagnosis. So a differential diagnosis is another diagnosis that could be occurring separate from what your field diagnosis is. So take, for example, chest pain. How many different diagnoses can you come up with somebody experiencing chest pain? A shitload. It could be acute angina, it could be a PE, it could be a heart attack, pericardial tamponade, pneumothorax, aortic aneurysm, all that kind of stuff, right? So, acid reflux, exactly, something as simple as that. So, we use our experience, our knowledge to try and wean out some things that it couldn't be, because typically these signs and symptoms are associated with this and not necessarily with this. So that's where coming up with your differential diagnosis comes into play, your experience comes into play. With our evaluation, we're going to exclude any unlikely conditions. So with chest pain, an unlikely condition would be fractured ankle. I don't know, something along those lines. Not to say you couldn't have a fractured ankle with chest pain, but if I'm working with somebody who calls because they're experiencing chest pain, I'm eliminating things that could not be causing that chest pain. And then, as you narrow down what you're trying to solve, figure out what's going on with the patient, you come up with your final diagnosis, which is your field diagnosis. Okay? So the emergency medicine approach to diagnosis, we're ruling out life threats. I'm not going to try and diagnose you with dementia or, I don't know, moya or something random like that, right? I'm here to rule out and figure out, are you going to die in this moment in time? That's our job. So, ruling out things, ruling out immediate life threats, which is a heart attack, a stroke, an aneurysm, a cardiac arrhythmia, any of those things that can kill you this moment in time, sepsis. Once we've ruled those things out, then we can start figuring out, okay, what else could be causing this? So gather information from the patient's family, bystanders on scene, whatever they saw might be helpful to you. Performing a physical exam. This is a big thing. If you go to a patient and talk to them about their information, they tell you they're experiencing abdominal pain. You find out how long they've been experiencing it, what their history is with it, you do a set of vitals. But you never actually look at their abdomen, feel their abdomen, listen to their abdomen. You're not helping yourself to figure out what's going on. Is it appendicitis? Is it a perforated bowel? They underwent some kind of trauma, and you would find a pool of blood or pooling blood in their abdomen. That's all stuff you can figure out, but you can't figure it out until you actually look, right? Every trauma patient you go to, you should be checking all their body systems, because if you miss a lacerated artery, that'll kill them, right? And that's something that you could have saved and stopped. So trauma patients, definitely, exposing, figuring out where their injuries are. Do your physical exam. Focus on ruling out worst case scenarios, so red flags suggest a serious problem. So I'm assessing somebody, we always get called to an unknown medical, right? Medical alarm activation. When we go to the patient, I'm looking for those indicators that tell me something really bad is going on. You're having chest pain, you've had a fever, your blood pressure's been low, your heart feels like it's racing, you were in a 70-mile-an-hour MPC and you weren't wearing your seatbelt. All these kind of red flags jump in our head, and those are key indicators to us that this patient could be sick and we're not going to mess around here. So you may be responsible for multiple patients. If we go to an MCI or you go to a 2-car MBC and you've got 4 patients there, that's where your triage comes into play to figure out, okay, who's my sickest patient and I need to deal with now, and who can I delay a moment to take care of the patient that's the sickest. We rule that by, are they conscious and breathing? Do they have a pulse? Are their vitals stable? Any excruciating injuries? That kind of stuff. So using your triage system to figure out who needs care first. So in the ER setting, the emergency physician assesses the patient, typically in a busy, hectic setting. There's multiple people, multiple patients that they need to see at once. 10 people walk through the door, they need to go and they need to see those patients. For us, we go to a call, typically we have 1 patient, right? It's not as hectic for us, unless you go to an MCI, then that changes. But for us, our focus is that 1 patient, all right? In an ER setting, their focus is multiple patients because multiple patients are under their care. But really taking the time, because you're the one who needs to figure out what's going on with that patient. When you bring that patient to the ER, they're going to base their tests and stuff off of the information you give them, what needs to be done first. So really take the time with your patient to figure out what's going on. So an EMS approach to diagnosis, be efficient. We're dealing with death and dying. I'm not going to sit on scene for 30 minutes, figuring out, well, your blood pressure's low. Let's stay here and figure out why your blood pressure's low. No, do your treatments to get their blood pressure up, fix their arrhythmias or whatever, and get them to the hospital. The hospital has more resources than we have in the ambulance. So, if you need to take the time, then take the time, but be efficient with what you're doing. And the reason for being efficient, so you're available for other calls. You know, if you're tied up on a scene for 3 hours, well, 5 calls come in during that time, and they're pulling from resources outside of your area. And, you know, that doesn't help those patients. So working in an uncontrolled environment, that's the nature of our job. Our job is to control that environment. So if we're on the scene of an accident on the interstate, having fire, PD, controlling traffic for us to keep us safe, controlling bystanders on scene because they're going to be hectic for you, they're going to be anxious and yelling and who knows what else. So separating that so you can do your job and do a thorough assessment. In our setting, we have limited tools and a limited skill set. So we have a cardiac monitor, we have a vitals monitor, and we have some tools to help us treat patients. But we don't have a lab, we don't have CT scanner, we don't have respiratory therapy or x-ray or any of that stuff. So literally we're, I don't want to say acting as field physicians, but in a way we kind of are, without all of their resources available to us. That's hard on us. So try and figure out that somebody's in septic shock and I don't have a lab or x-ray or anything like that. That's the nature of our job, right? Narrow educational focus. I don't really like what they say about that because it is a narrow educational focus in the aspect of we're dealing with pre-hospital emergency care. We're not dealing with hospice care. We're not dealing with nursing home care. Our job is pre-hospital emergency care. So that is our education, that is our focus. We become experts in that field, right? Whereas a nurse has to be an expert in a broad range of healthcare. But that doesn't mean they go so deep as we do in pre-hospital emergency care because we're the expert in that setting.
Well, just a caveat off that, like what is kind of nice is so the class, like Garrett was saying, is like we're focused on pre-hospital emergencies, but in your career you'll be exposed to hospice care, nursing home care, all sorts of different fields that, like you may not be working directly in it, but you'll take a number of nursing home patients, you'll eventually figure out kind of how the nursing home works. You'll take a number of hospice patients, you'll figure out kind of how that works. So it's very like, some medical professions, it was like, this is what they do, that's all they do, and they don't see anything else. This is very broad spectrum, so I would agree with you. I don't really like how they say narrow educational focus because we get a lot of exposure to all sorts of stuff.
And the thing with that, so nursing homes are a great example. They don't deal with a lot of acutely sick patients very often. So Mary Jane falls off the bed and she hit her head, and to them that is the worst case scenario because they're concerned of 100 different things that are going on. For us, we see that on a regular basis, and we can kind of figure out right off the bat, do they have a TBI or a stroke, or do they have a concussion? Is this life-threatening or is it not? So they're not exposed to this as much as we are. So that's why we're kind of the experts.
And that's something I don't know if I don't know if we've talked about it previously in another class, but as you get into this, your day-to-day life of going to these difficulty breathing calls, these chest pain calls, these traumatic injuries, for some people, that's going to be
never seen it before.
They've never seen it before, and it could be the most devastating medical event they've ever experienced in their entire life. To you, it's just another shortness of breath call, it's nothing. So it's just something to keep in mind when your patient's freaking out. You're like, what the problem is? I'm just going to do some albuterol, you'll be fine. But they're losing their mind because they've never felt what it is to not be able to breathe. So just
that's where your expertise, your experience, and your calm demeanor come in. Be confident, be calm, because if your patient's freaking out and you start freaking out,
hysteria is contagious.
Yep. Absolutely. What you see on your patient is basically a reflection of what they're seeing on you. So if you're panicking with the situation and you don't know what to do, they're going to panic as well, and it just makes everything worse. So be confident in yourself. You're the experts in this field.
It kind of comes with that. It's like controlling your face a little bit. It's nice with the mask.
Nice.
With the mask because you can roll up and be like, And they can't see your mouth well,
Right.
but you know, like dark sunglasses hide the fear in your eyes.
Right.
Like you just look stoic. Like so.
Wear dark sunglasses.
Yeah.
To everybody.
Yeah. See, look.
It's not.
You can't hide the. You can't see the fear.
Yeah, until you're in the house and they're wondering why are you wearing
Yeah. Why are you wearing
sunglasses?
sunglasses?
So any questions with that? Pretty straightforward. So our approach in diagnosis is very similar to what the ER does. We rule out any life threats and we try to come up with a diagnosis that's causing the patient's symptoms. With that, we caveat in what other diagnosis could be occurring in our differential diagnosis. This is the same approach the ER does. When we go to a chest pain, the ER is going to handle that chest pain the exact same way we're doing it in the field. They're going to get vitals, they're going to get a history, they're going to get a 12 lead. And then the only difference is they're going to draw labs. Other than that, same thing we're doing in the field. It's no different. Cardiac arrest, that's why cardiac arrest, if we don't get ROSC in the field, we're calling it in the field. Because the ER is not going to do a damn thing different than we're doing in the field. So a lot of our approach is based off of the ER approach. Most are abbreviated and limited, so the ER does have more access to resources than we do. They consider most serious conditions associated with the patient. So they're ruling out the major conditions, the major life-threatening events first, just like us. Creating a diagnosis. We come up with a field diagnosis that we believe is causing the patient's symptoms and we try to treat that. With that, we're maintaining a differential diagnosis, keeping our eyes open as to other things that could be ongoing. But it's the same approach as the ER. So think about it. You can reach diagnosis, but your work is not done. Why? So we've done a great job. We've done our assessment, we've gotten a full history, full set of vitals, and I'm coming up with a diagnosis that the patient's having an MI.
Treat.
Is the work done?
Constantly be
We could be
reassessing.
wrong.
Things can change.
Reassessing? Absolutely.
You might have diagnosed it wrong, so you need to think about other things that could happen.
That's where prevent that narrow vision, right? I'm diagnosing you with an MI, it may be a AAA. They can sometimes present the same. So if I'm saying it's an MI, I give a patient nitro, I just killed them, right? And that was because of developing a narrow field on that. So reassessing your patient, treating, working with your field diagnosis, and then keeping an open vision as to what's going on with that patient, you know, what other things could be causing this. So no, the work is not done. Experienced physician learn heuristics, so shortcuts. So it's pattern recognition, so when you go to enough chest pains, you'll start to associate certain symptoms with, you know, a particular diagnosis. If I go to a patient with GERD, the most common symptom we hear is a burning sensation in their epigastric region, right? Doesn't mean that they're not having an MI. Most often, it's acid reflux. A similar thing, I'm working with somebody that's having an MI, but they tell me they lean forward and the pain stops. Well, typically associated with raising your shoulders and leaning forward, pericarditis. You can differentiate pericarditis and an MI just on that simple symptom. So there's multiple diagnoses that have their own caveats, and you'll kind of learn them with experience and as we go through pathophysiology. But it's just developing that pattern recognition to lead you down a certain path. Reach difficult diagnosis more quickly. We're not necessarily going to come up with difficult diagnosis in the field. You can base that off of history. So if somebody tells me they have a history of moya moya, and they're saying that they've had syncopal episodes and symptoms of a stroke, well, maybe it is moya moya. I don't know if you guys have ever watched The Resident or not. Eric's had a patient with moya moya before. It's a very rare diagnosis, but figured it out in the field. But we associated that with their previous history, and it's similar to their previous history. So that's what we're working with.
The story is very politically incorrect, and it's hilarious. I'll share that with you at some point.
When you're not being recorded.
Yours?
Yeah,
or-
the Moya Papa smoke. So.
Yeah.
For a case review, it's a great case.
Yeah.
John tells us better.
John does tell it better.
Yeah.
So. Well,
So,
perfect. He'll be back when these guys are done, and he can tell them what.
there you go.
Yeah, there we go.
So that's really, it's just associating certain symptoms with certain diagnosis. And you'll develop that with your experience and as we go through this course. Realize the limitations of shortcuts. So understanding common biases of heuristics. So that's where kind of our frequent flyers can affect us. We go to the same patient 10 times in a day. And we go to the same signs and symptoms. And we say, you know what, it's got to be this going on. I'm developing the narrow vision of this because it has to be this. I've been to this patient 10 times and it's the same every time. I'm limiting on myself and I'm taking for granted what could be going on, okay? And that can be detrimental to the patient. Don't take anything for granted. Don't develop your narrow vision. Don't always assume I'm seeing these signs and symptoms, so it has to be this, okay? We use those shortcuts to help us and treat the patient more quickly, more efficiently. But keep in mind that every patient's different. We have a accumulation of symptoms, but they're not always leading to one thing.
Yeah, the frequent flyer thing can that can be almost dangerous because you run this patient who has the same symptoms all the time. Eventually, it becomes routine. You become a little annoyed with them, and you just have much more of a tendency to miss things. Like we had a guy who was brittle diabetic. Went to him basically every day with a low blood sugar. We would, we'd go in, we'd give him D10 or D50. He would perk right up and he would refuse transport and all would be well in the world. One time I went to him, he was doing his thing, typical presentation. We gave him the D50, checked his sugar, he was good, walked out. And on the way back, we're like, we didn't check his sugar before we gave him D50, because he was just doing his thing, so we didn't even, we forgot. It was because it became so routine, potentially his sugar could have been through the roof and we could have made it way worse, but it was just, I use that as an example of
That's a perfect
getting,
example of this.
just getting that tunnel vision, it's getting so-and-so, and do your thing, just keep that in mind.
Yeah. Yeah, like you said, our frequent flyers can be our most dangerous patient. That's our most liable patient. Don't be complacent with them, right? Because it's those times that you go to them and you miss something, and then 2 days later they could die from it. That's on you, right? So don't be complacent with your frequent flyers. Take the time with them. Figure out what's going on. So common heuristics. Representativeness, availability, overconfidence, confirmation bias. Your book goes into all of these, but Joe was nice enough to sum all these up for me here. So, representativeness. When you see a patient with symptoms that represent a particular condition, so pattern recognition. What's a common symptom of a heart attack? Chest pain.
Arm pain.
What population typically can present different with an MI? Females. The most common symptom for females with a heart attack is neck pain or jaw pain and abdominal pain or nausea. It's not always chest pain. Typically, in males, it's chest pain, left arm pain, that kind of stuff. But associating, the common signs and symptoms. Every female patient we go to that's experiencing abdominal pain or jaw pain, left arm pain, that kind of stuff, you absolutely should be getting a 12 lead. If you don't get a 12 lead, then you could miss a heart attack, and that's going to be detrimental to the patient. So, small pattern recognition caveats like that. Availability. So availability, easily recalled due to recent exposure, can cause EMT to think it's more common than it is. So, how often you see those associated signs and symptoms with a particular condition. It's really based on your experience with that, how often you see it.
Well, it also goes to it's a little bit more than that. Maybe my note wasn't super clear, but it's going for things like just had a patient with that had a thoracic aneurysm, like a TAA, and now the 3 patients later you have a patient that has the exact same symptoms. So you're like, this is the same thing. I just had a patient with it. When in reality, a TAA, a thoracic aortic aneurysm, is an extremely rare occurrence, and most likely you're not going to see one in one day, let alone the same year.
Yeah.
You probably may see one in your entire career. So that's what availability is really talking about, is associating a previous patient with another patient because they have the same symptoms.
Yeah. Overconfidence. So this can work against EMTs. Certain amount of confidence is healthy. Too much, and it can affect our ability to see the picture. I love this. So we see a patient with a particular symptom, and we say, it's got to be this. They're having chest pain. It's got to be a heart attack. Developing overconfidence and kind of losing your field of vision on what else could be going on with that patient can affect that patient's outcome. So don't be overconfident in your work. Have some form of confidence, because if you're not confident in taking care of that patient's not going to be confident in you taking care of them. So keep your eyes open. Don't just assume, patient's presenting with this symptom, so it has to be this. Okay?
It's a fine line.
It is.
It's a fine line to walk your confidence with overconfidence. Because you should be confident in your own abilities, your own knowledge, but it's a very fine line to walk, to not sound
Absolutely.
cocky, and so just keep that in mind.
Yeah.
We all struggle with
We
it
all
from
do
time
it.
to time.
Yep. Confirmation bias. You look for evidence of a diagnosis you already have in mind. So this is where you believe this is what's going on for the patient, and you're trying to prove to yourself that it's this. Okay? So a patient's presenting to me with chest pain, and I'm looking for reasons to say it's a heart attack. Because of that, I'm not ruling other things out, like, is this a PE? The patient's telling me they're short of breath. Well, they're short of breath because it's a heart attack. Maybe it's a PE going on, or maybe it's a pneumo, right? Don't take all the information they give you. Don't just narrow yourself to one diagnosis and only incorporate the things that fit that diagnosis.
And you can get that from, you can kind of run into this with your dispatch information, because you're dispatched to a person who believes they're having an MI. So then you and your partner are like, okay, let's bring in the monitor, let's do this, let's do that, the other thing. You're spooling everything up to run a chest pain scenario, and then you get in there, and if you don't take the picture for what it is when you get in there and do your own assessment, then you might find out it's not really chest pain. It's more like a difficulty breathing with some chest pressure, or something. When dispatch, they're just professionals at playing the telephone game. So you might be going to an arm injury, and it turns out to be a leg injury, or you can get that from dispatch a little bit too.
Absolutely, yeah, and that can get frustrating. So take all
Or
the
you get
information
patients,
that's
or
given
you get people that will call 911. It has happened, does happen. They will lie to the dispatcher about what the problem actually is going on, because they think it will get them an ambulance faster.
Yeah.
So if I complain I have chest pain, when really it's because I haven't pissed in 4 days, they may do it because, it'll give me an ambulance faster. So I'll say I have chest pain. And
Or they don't want
it
to dispatch, out on a radio,
I mean, it's not dispatch doing it, it's the person
No.
telling.
Yeah, but it might be the caller being like, I don't want them to dispatch an ambulance to
My house where everyone knows.
Yeah, I mean,
me,
possibly
or-
too, but
in small town Vermont, everybody knows that.
Right.
Everybody knows where Greg lives. So you're like, I got something wrong with my butt. They don't want that on the airwaves in Scannerland. So
We're
yeah,
supposed to count there.
Yeah, no, exactly. So don't just, as soon as you walk in, don't develop that narrow vision. Take in everything that the patient gives you, and then figure out from there what it could be that's causing your symptoms.
Can I just stop you for a second?
Yeah.
You said it could be a PE or a pneumo, obviously pneumothorax. What is a PE?
So pulmonary
Okay,
embolism.
okay.
So
I
basically,
just
blood
was
clot. Yeah, no,
missing.
we haven't touched patho, so I'm not expecting you guys to know that stuff. But when we go down patho, you'll see.
Okay.
But yeah, pulmonary embolism is basically just a clot in your lungs as opposed to your heart. But they can present the same, but there are some caveats, some differences. So illusionary correlations. Two events that seem connected but are in reality separate and unrelated. So this is where you're trying to differentiate between two different symptoms that are ongoing. So let's say, for example, a patient's having a stroke. They're presenting classic symptoms of a stroke. They're altered, they're facial droop, they're pale, diaphoretic, and sweating, and I'm leading down the path that this is a stroke. maybe it's a hypoglycemic emergency. 2 different symptoms. I forget to check a sugar, and I'm leading down the path. I'm bulleting to the hospital, hey, this patient's having a stroke. I never thought in my mind, what else could be causing this? Hypoglycemia can present just like a stroke, and that's why we check it, right? So that's why we work down those symptoms and those systems to figure out, making sure we don't miss anything. I think I explained that correctly. Anchoring and adjustment. I think it's one thing when the evidence may point to somewhere else. So you're leading down a path that this is a heart attack ongoing, but the evidence is pointing you towards, I don't know, an aortic aneurysm or a stroke, whatever. So again, kind of the same thing. Don't be fixated on one thing. Take all the information that's given to you and just keep it as a differential. My differential is that this patient's having a heart attack when all the evidence is pointing to me that they're having a PE or an aortic aneurysm. Okay. Again, just keeping an open field of vision. And then search satisfying. This is a good one. You confirm a finding, a field diagnosis, and stop searching. Many patients have more than one problem. Okay? This is a good one. So you've come up with, you've got your patient assessment, your vitals, your medical history, your physical exam, and it's coming out to you that it's a heart attack going on. And then you stop. You say, it's got to be a heart attack. I'm not going to look for anything else because this has to be what it is. That's where you get into trouble. Okay? That's where you miss things. Maybe you miss the fact that a patient's got a pencil sticking out of their back and that's causing their neck pain, whatever. Ask the appropriate questions. Use that to rule things out and then also rule things in that can help you out with your diagnosis.
It's kind of like the same thing that Joe was talking about when he was saying, we were talking about the tests, and he's like, always, strip your people on your tests because you never know what's going to be.
Exactly. Don't stop searching. Even, I've come up with my working diagnosis, we're on the way to the hospital, reassessing that patient, and then looking for things that you missed. I forgot to check a sugar. Perfect example. That's a quick thing to check. It can rule in that this is a diabetic issue or it's not a diabetic issue, right? That's basically the whole point of that. So how an EMT can learn to think like an experienced physician. Learning to love ambiguity, understand the limitations of technology and people, realize that no one strategy works for everything. Come up with your own strategy, how you're going to ask, how you're going to approach a patient. Form a strong foundation of knowledge. That's why you're taking this course. Organize the data in your head. This is probably one of the hardest things that we can do. Taking all the information that the patient's giving to you, just their medical history alone. You're going to go to a patient that's got 20 different prior diagnoses, and you're trying to associate, well, can any of these diagnoses fit with what's going on right now? Organize the information to what's relevant to what's going on at that moment in time. Changing the way you think. So adapting. You need to be adaptive with these patients. If one approach works towards one patient, but it may not work the same towards another. A lot of psychs, that's a big thing. Psychiatrics and kids. You may have to change your approach, the way you ask questions, the way you're taking in information. Learning from others, so with experience, learning with your partner, going to QA sessions, that's invaluable because that's stuff you can take back when you're actually in the truck. And then reflecting on what you've learned, debriefing after a call, figuring out, what did I miss, what did I forget, what did we do well on that call, that kind of stuff. All right, we'll skip over that because we've got a whole other thing to go to. Sorry, I know that stuff is kind of long and elongating, but this next chapter is a little more interesting. Let's look at this. So give me like 5 minutes to get this all situated. EMS operations, so this one's a little more interesting. This is where we're actually going to talk about the trucks, so your office that you're going to work in. We've got 3 of the 4 types of trucks here at the station, so we're going to go through those. just so you understand. I got asked that on my EMT exam, knowing the different types of classes of trucks and the different components to them and that type of stuff. So that's what we're going to talk about tonight. So, preparing for the ambulance call, receiving and responding to calls, transferring the patient to the ambulance, transporting the patient to the hospital, transferring care to the emergency department, terminating the call, and then using air rescue, the whirlybirds. So we're going to talk about all that tonight. So, preparing for the ambulance call. First, you need to know the different classes of ambulances. There are 4 different classes of ambulances. This one is the most common. This is a Type 1 class ambulance. Once I go through these, then I'll take you guys outside so you can actually see what they look like. So a Type 1 class ambulance, it's the most common, pretty much, all services in Franklin County have this class of ambulance. So it's basically a truck chassis that's purchased separate from the patient compartment box. So when a service goes to buy an ambulance, they buy this component and the back and not the box. The box comes from another developer. So here we use Braun, there's Osage, there's Demers, there's Wheel Coach, there's 20 different styles of ambulance boxes that are purchased. But a Type 1 class is chassis separate from box. Okay? Type 2 is a van style. We also have this here. There's a couple other services. I know Missisquoi and Enosburg. Does Richford have?
Enosburg got rid of theirs.
Oh, that's right. They sold to Missisquoi.
Yeah, we
right?
just have 2 bronze now.
2 Browns, gotcha. Lamoille uses these style of ambulances. They're handy because they're efficient. They're very narrow in the back, and you'll see that. We'll see one of ours here. But they're great for maneuvering in the city. That's the one part about these I love, and they're very fuel efficient. So a Type 2 is a van style ambulance. Mercedes has one, Ford has one, and then Dodge has one as well. A Type 3. So a Type 3 is a combination of a van style and the box in the back. So it's basically taking the front end of a van and attaching a box to the back of it. So these are a little bit bigger than the Type 2s. They're definitely smaller than the Type 1s. But these are great because you can access both sides of the stretcher to the patient, just like a Type 1, whereas a Type 2, you can only access one side of the patient. So these are Type 2s. These are very common down south. Not very common up here. We do have one. There's a few other services that have them as well. But they are fuel efficient. Type 4, so a medium duty truck. These aren't as common. There's a few services that have these. Alberg has one. Milton has one. Those are the only 2 that come off the top of my head. Fact has one similar to this. It's actually a little bit bigger. That would be a large duty ambulance style, but these are great for, it's a bigger patient compartment in the back. It can hold a little bit more equipment. Power-wise, they do have a little bit more power. Usually it's a Freightliner or International engine that's used in these trucks. So these are the larger, basically, the front of the body is a over-the-road truck style.
Why go so big?
Depending what your service use for as it is, these are used a lot for bariatric transports. That's a common one. Other than that, it's if you need it and you want it, you don't have to have one this big.
Isn't this what UVM has for their fleet, or do they have the large duty?
Bigger, large
Yeah.
duty. Yeah. So UVM basically take this component and add an extra row of seats in the back. So all the crew can ride in the front compartment when they're going to do a transport or whatever. Their box is always bigger, also bigger as well. It's basically, picture an ICU room. That's what their box in the back is. It's huge. But they need that because they're doing critical care transports. So sometimes they'll send a NICU team, which is a NICU physician, typically 2 critical care nurses, an RT, and a critical care paramedic. So you're fitting 5 to 6 clinicians in the back, plus the patient.
That's the unit that would go to Plattsburgh for brain injury and bring it back to Burlington.
Not always. So they have 4 different units.
Okay.
They just purchased 2 new ones. So the NICU one is actually developed for that setting. It's actually, the stretcher is different as well. It's actually, instead of your typical reclining stretcher, it's actually an incubator on a stretcher. So it's able to monitor temperature, provide the temperature needed, oxygen concentration, all that stuff. So that's what they use for that big truck. They can swap out stretchers and also use that for critical patients as well, but they don't use that big truck for your typical non-STEMI runs and that kind of stuff. And then your specialty vehicles. This is actually the Vermont Hazmat truck. It's a fire truck developed for Vermont Hazmat situations. We have VSP has a bomb squad truck, different fire apparatuses. There is actually an MCI trailer. I forget where it's housed. I want to say it's in Colchester. But there's an MCI trailers. There's different forms of equipment that we use depending on what's needed for resources. So these are the different units available to us. Also the Whirlybirds. In the EMS setting, you have fixed wing and you have rotor wing. So those are 2 terms you hear. Rotor wing is helicopter, fixed wing is flight or plane. So depending, planes are typically used for long distances, going from Europe to here or going from here to Winnipeg. Those happen actually pretty frequently. We pick patients up at Heritage Aviation, which is right across from the Burlington Airport. We'll pick patients up on fixed wings, bring them to UVM with the crew, and then bring them back to the fixed wing. So, some cool stuff. Ambulance supplies and equipment. An ambulance without proper equipment may have its agency cited and fined a considerable amount of money by a state or EMS regulatory agency. So every ambulance has to be licensed by the state and by the DMV. Okay? You can't just buy a truck, throw it on the road, and say it's an ambulance. It doesn't work like that. So every 2 years, at least for the state of Vermont, the EMS office, the Vermont Department of Health, comes down with a team. They go through every ambulance for each service, and they make sure that it has the requirements to be legal and to be on the road. If that ambulance fails, that doesn't mean the entire agency fails, but it means that particular ambulance cannot be placed back into service until it passes inspection. So they're starting it again if you guys are ever interested in it. Once you get your EMT license, the state's always looking for people to come down and help them go through each unit if you're ever interested in. So yeah, you can face fines if a particular situation comes up and they find out your equipment malfunctioned or whatever happened on the call that was detrimental to the patient. The patient can sue you, and then you can face legality on that. So always, every morning we do a rig check. Every service should do that. As soon as you get on shift, you're checking your truck to make sure you have your equipment that you need. Learning where each item is, how to use it, and when it should be used. That's the whole point of this course, is to teach you, how to use your equipment, what the purpose of it is, how to assess patients, that kind of stuff. So when you get signed up on an agency, take the time, that should be part of your orientation, to figure out where all the supplies are in your ambulance. Some services only have 1 truck, so you just need to learn that 1 truck. Some services have 10 trucks. Each truck might be a little different. In general, like in our situation, all our trucks are set up the same. Airway supplies are here, trauma supplies are here, bandaging is in this location, that kind of stuff. So it makes it easy for us. We can jump truck to truck. Ensuring ambulance readiness for service. So be sure that your vehicle and your equipment are ready to respond when an emergency occurs. That's why we do rig checks right off the bat as soon as we get on scene, or as soon as we get on shift. During shift change, receiving a shift report. So I'm coming on shift. The crew that was in my truck is going to tell me, hey, we had a busy night last night. We didn't get a chance to resupply IVs or O2 or whatever it needs. Take that report from the crew, so that way you know right off the bat, what do I need to grab for the ambulance, so I know it's ready to go. 2 components So you have the vehicle component completed by the driver, so ensuring that this component of the ambulance is good to go, making sure you have your registration, your insurance information, you have fuel, making sure the lights, there's no lights on the dashboard appearing that would put you out of service, making sure you have your keys, kind of all that stuff that we can be complacent about.
You check
Making sure
fluids
you
too,
have-
like oil and all that?
Absolutely, yeah, that's part of our check. So all the fluid levels, transmission, oil.
I'm not a mechanic, but I still look at it.
Yeah, that's it's not empty. We're
There's
good.
liquid on the stick.
Looking at when is the next oil change due. All that stuff is encompassed with it. So that's one portion of the ambulance that we check out. And then the second component is the patient compartment. So that's why in our rig checks, we have two separate sheets. One is checking the physicality of the truck, the other is all the patient supplies. So they say completed by driver and crew leader, depends on the system you work in. You know, some systems, they have a designated driver and a crew chief. Our system here, we both do the same. You know, just because I'm a paramedic doesn't mean I can't drive the ambulance. And same with my EMT or AMT partner. Doesn't mean that they're not going to care for patients in the back. So we work together on that. So this is just covering all the different components of the ambulance that we need to check, making sure it's ready to go. Any of you guys ever taken an EVOC course? You've taken EVOC? You've taken EVOC? Okay. EVOC, they preach this like crazy, checking everything on your ambulance to make sure it's ready to go. Derek and I are actually going down soon to be EVOC instructors, so eventually we will host an EVOC session up here.
We get to take a business trip.
Yeah.
Where are you going?
Buffalo?
I'm sorry.
Yeah, I heard.
Yeah.
I've never been, but you know, whatever. Like,
I'm a Bills fan, so I'm all about it.
we'll just go get stabbed.
I'm sorry.
We're doing good right now. So yeah, EVOC course, if it's available to you guys, I highly recommend you take it. As a caveat, you can use that EVOC certification towards your personal insurance for your vehicle, and most insurances will deduct your payment.
I assume that's an acronym for something. What is that?
Emergency Vehicle Operators
Say the thing about the car insurance again. What?
You didn't know that?
I didn't know that. Dude, I'm calling him tomorrow.
Yeah. Certain insurances. I know Geico has it, State Farm has it.
I got
Allstate has it.
Yeah, they do. Shit, dude, I'm gonna pay less.
If you have your EVOC certification, you submit it to your agent, and your agent can take that and say, okay, you
So,
can deduct.
when I took my EVOC course, I was actually insured through the co-op.
Yep.
And I called my insurance agent because they said that during the course, and she was like, yeah, so I actually don't tell them you're a fireman because that increases your rate.
Oh.
And then the EVOC course doesn't bring it all the way back down. So,
Well, that sucks.
little caveat.
Is it just because you got lights on your rig?
I guess, I don't know.
Yeah. If they,
Yeah, Geico didn't ask me if I was on any emergency services, so.
Yeah. Add their app or whatever.
Yeah.
There's a place you can put it in there.
Oh, cool. I'll need my e-box tomorrow, Garrett.
It's in there.
It's in
The
there.
ability to not interact with humans when dealing with insurance is
I
just.
know.
Will you like scan the certificate or just?
It depends. They may ask you for it.
Okay.
Usually they require the date you took the course and then the date that it expires. So EVOC is good for 2 years.
Oh, shit.
Damn.
Way longer ago.
My e-box is like 6 years old.
Yeah, EVOC, services are dependent. Some services don't require you to have, EVOC recert every 2 years. Ours now does. So every 2 years, every employee here has to keep their EVOC up to date.
Yeah. We'll have to spin up a class pretty quick once we
I was gonna say,
get.
so I will need to take a class now. Gotcha.
We are going to. Yeah.
Yeah. We get a lot of new people coming on who've never even driven an ambulance,
Yeah.
so. Right.
So we'll be doing that. So part of EVOC, a big thing that they talk about is checking the equipment, checking the safety of the physical ambulance. So tire pressure, that's kind of important. Most new trucks nowadays actually have a gauge right on the dash that tells you your current tire pressure. Don't always live by that though. Actually get out, check the tire pressure. I carry one in my truck on me that reads out a number to make sure that it's good to go. Where we get into trouble is a lot of times on the inner tire of these trucks. You'll notice it when you're going down the road. It's extremely wobbly. You say, hey, I don't know what's going on, but the brakes or something are bad on this thing. It could be as simple as an inner tire is low. So take the time, check your tires, check the wear and tear on them. Windshield wipers, That's another thing. The wheels, ambulance body, making sure there's no big dings or dents in it.
Yeah, that's one thing I was gonna say, like, beginning of your shift, you know, check and
Just do a walk around.
Just do a walk around if there's any damage to the ambulance, because that way then you can report it to your supervisor, and then you don't get blamed for it. Because somebody might have parked the truck and walked out,
Not me.
and then if you don't check, later it'd be like, hey Derek, like, what the hell is this? It's like, well, that was there. Like, was it? Like, why didn't you? Why are you telling me now? Why am I finding it 8 o'clock at night?
Yeah.
You know, so just one of those things.
So in other words, don't take Russell's trucks.
Don't take what?
Russell's trucks.
Actually, Russell's been good. I don't think he's ever.
Well, just that one event.
Yeah, just
Yeah, just that one.
Poor Enosburg ambulance got sideswiped
Oh, really?
Tuesday night. Yeah,
Oh, boy.
somebody pulled out, like, right in front and just sideswiped him.
Oh,
Took him up right off the bat.
What services were?
I never understand how you hit.
Apparently there was a service that was responding to
like that.
a call for a car accident. Somebody had hit a moose. And while they were responding, they hit a moose.
Oh, it
Like,
was
last
Orange
week?
County.
Yeah, it was somewhere up in the Northeast Kingdom.
I'm not surprised to see all this thing. There's more voices than people.
I don't know if it was Newport or...
Those are people.
Those are people.
They count them in the census.
Yeah. So, yeah, do a walk around your truck, looking for dings, dents, that kind of stuff, making sure your truck's good to go. On the interior of the ambulance, checking interior surfaces, upholstery. So, something that to keep in mind, if you have your upholstery and you have a big open portion of it, that's a contaminant. You can't, it's all foam inside there, and if blood or, God, whatever fluid gets in there, it's contaminated. You can't just wipe it out, right? So that's why the upholstery we check to make sure it's good to go. If it needs to be reupholstered, making sure we have adequate supplies, so if we need to run on a call. With that, I will also say, if you get into a dirty truck, look to make sure there's no blood or urine or anything on the floor or on the side cabinets, that kind of stuff.
Needles
Needles.
laying around.
Yeah. So, do a check, making sure you're not missing anything that could expose you or expose a patient. So, ambulance inspection with the engine off. Inspect the body of the vehicle, report any damage that may be evident, indicate damage that has not been repaired. So if it needs to be pulled out of service and repaired, you've recognized it at that time, that ambulance is going out of service until it's up and running and good to go. Inspect the wheels and tires, check for any damage, wear and tear, damage to the rims, sidewalls, tread depth. Winter in Vermont, you want good tires, you want good tread. So if your tread is bald as that table, not a good truck to pick in Vermont in the winter. Using a pressure gauge to track your pressure tires, your tire pressures. Inspect the windows and mirrors, making sure there's no grime, bugs, or any of that stuff that can impede your vision and view. Look for broken glass and loose or missing parts. See that the mirrors are clean and properly adjusted for maximum visibility, so we'll go through that. Adjusting the mirrors, that's the first thing you should do before you go to a call, making sure that you can see clearly with your mirrors, because you can't just look in the back and nobody's there. Check the operation of every door and all latches and locks. So making sure that if you lock your truck, you can unlock it and it actually opens, right? You don't want to not be able to get in the back of your ambulance when you're on call.
One thing, just winters in Vermont on washing your truck. If you wash your truck when it's like -30 out,
Yeah.
and you have to pull out immediately, the back doors will freeze shut. It's
Yep.
happened, and you can't get the back and
Some of the compartments.
compartments. Yeah, exactly. Like you go to get the back board and you can't get the door open. Like
Yep.
that's happened.
Whenever we wash our trucks, we dry rag them. As soon as we're done washing, we open up all the compartments, we wipe down the sides, the interior, all that stuff, so that way that doesn't happen. So, good point. Same thing, road salt and rust, wear and tear on the trucks, it happens. Unfortunately, we have salt up here. So latches can get worn out and rusted out, so making sure you check those, that everything opens up. Check the fluid levels. So we're not expecting you to be mechanics, but understand that you need fluids to run your vehicle, just like your regular personal vehicle. You need brake fluid, you need transmission fluid, coolant, oil, all that stuff. If you go to a call and your truck dies because you didn't check the oil level, unfortunately that's on you, right? It's your ambulance, it's part of your job to inspect it and making sure it's operational and good to go. So that's another thing we do every morning. Pop the hood, check to make sure fluids are good to go. Batteries, inspecting the battery, cable connections, ensure they're tight, no signs of corrosion on the batteries. Inspecting interior surfaces, upholstery, damage and cleanliness, making sure there's no fluids or anything. Wipe down the steering wheel with disinfectant, so after every call we decon the truck, especially COVID times. Every call we went to got a full decon. COVID's dying down, that doesn't mean we stop decontaminating trucks. Okay? Check the windows for operation and cleanliness, test the horn, siren, emergency lights, so we'll do that here afterwards. Making sure that all your emergency lights are working, making sure your siren works, do a walk around. Adjust your driver's seat, ensure the seat belts are operational. Non-operational seat belts are a hazard. You can't operate a vehicle if you don't have working seat belts. Plain and simple. You can get pulled over by the DMV. They check your seat belts and your seat belts aren't working. Guess who's getting a fine? You. Check your fluid levels, your fuel level. Refuel according to agency policy. Here we typically refuel once we reach half tank. So checking under the hood. I would recommend wearing gloves. She's not wearing gloves, however, fluids, especially throughout the day, if you get oil on you, grease, whatever, that's going to be on you the rest of the day.
Especially if you wear these white shirts.
Yeah. So wear a pair of gloves. Check your fluid levels, making sure they're good to go. With the engine on, so you turn the engine on. Number one, as soon as I turn the engine on, I'm listening for any abnormal sounds. As soon as I turn the engine on, do I hear any funky bangs or whistles or belts that sound squealy, that kind of stuff, pulleys or whatever. Check your dash, make sure, just like your car, is there any dash lights on? Is there an engine light on, an oil light on, that kind of stuff. Pretty simple, straightforward. So you're checking your dash gauges, depress the brake, making sure the brake has resistance so you know you actually have functional brakes. Note pedal travel. If it pushes all the way to the floor, you don't have brakes.
You should probably check the brake fluid again.
Probably, yeah. You don't want to go on a call and not have brakes. If you have a fire apparatus, they use an air braking system. In our trucks we have hydraulic brakes, so we check hydraulic fluid levels. In an air braking system, they actually are connected to an air compressor when they're not in use because they rely on air pressure to stop them with brakes. I don't know of any EMS ambulances that use air brakes.
Is that what the hoses are that fire trucks usually have attached to them?
Allbirds.
Yeah.
Yep.
All
So that
birds
is actually going for their brake system.
It actually works the opposite.
You don't mean the hoses that
What's
go
that?
out from the side.
Actually
The
works
big
the
yellow
opposite.
ones.
The
Nope,
air,
that's exhaust.
Oh.
the air disengages the
So-
brakes.
Really?
Yep.
Oh, I didn't know that.
If you don't have air, then your brakes are stuck on.
This guy,
Oh,
I don't know
shit.
what he said. He covered
Huh?
it.
I didn't know that. I
You ever
never
going down
thought
the road and you see like the dually marks, just, it's because they lost too much air pressure.
Okay. So, interestingly, I don't know why fire trucks are designed this way.
It's,
Their air horn runs off of the same air pressure system as their brakes. So if somebody wails on their air horn, they've lost all their pressure in their braking system, so their brakes lock up. I guess would be the.
also if you pump your brakes too much, you can lose a bunch of that air pressure. So the compressed air helps to disengage the brakes is what happens. So when you push your foot on the brake, you're releasing air pressure and the pads come together.
Yeah,
And
makes sense.
it's so that if you lose all your air pressure, you stop
Yeah.
instead of
As
the
opposed
opposite.
to the opposite where you can't stop. Yeah, that makes sense. Those air pressure systems are more for bigger rigs like tankers, engines, over-the-road trucks, that kind of stuff. In our ambulances, we don't need air braking systems realistically. FACT uses those because they have bigger trucks, but for us, we just use hydraulic brakes. Test the parking brake. Derek learned this one. Wasn't it you that left the truck in park and you did your job? You put the
Oh yeah, I left it in
Parking
drive. Yeah, I left it in drive and set the parking brake. Truck didn't move.
parking brake worked.
Parking brake worked. But when I got back in, like, whew, Whoops.
So, it can happen. We get
Not
out,
me.
we pull our trucks out to the tarmac, we press the parking brake. With the parking brake, that actually engages our high idle, so it charges our batteries and all that stuff. That's the first thing we do. Sometimes we forget, oh shit, I forgot to put it back in park. That's why we check the parking brakes. Anytime you park on a slanted hill, engage your parking brake. Anytime you get out of the ambulance, you're on call, engage your parking brake. Okay? For
You
your
guys don't
safety.
have wheel chocks or anything.
No.
Bomb sales already work.
Fire apparatuses, that's required. EMS, not so much. It's actually a good idea to have though, especially if you're on a hill.
Basically avoid being on the news for ambulance
Running.
smashing into something.
Yeah. That definitely wouldn't be good.
This work for Lemoyle.
Yeah, yeah, Memorial's another story. So move the transmission, so you set the parking brake, you can actually engage the drive, so shift your transmission into drive, the parking brake should hold you. If the parking brake's not holding you, that means you don't have a functional parking brake, just like your car. Replace the level to the park position as soon as you are sure that the parking brake is holding. Turn the steering wheel from side to side, making sure you've got full travel with each direction. Check the operation of the windshield wipers, washers. Glass should be wiped clean each time the blades move. If you see a floppy windshield wiper, replace it. Turn the vehicle's warning lights on, making sure your hazards work, your emergency lights work. Do a walk around, either you or your partner. Left directional, right directional, brake lights work, all that stuff. So making sure those are all stuff that can go against you if you ever got pulled over. And yes, ambulances can get pulled over by PD. Just heads up. Turn on the other vehicle lights. So do a walk around with you and your partner. Check the timing of headlights. Turn signals 4 ways. Scene lights. So we have side scene lights, rear scene lights. Anytime we go to out in the middle of nowhere, we use our scene lights, especially on car accidents in the middle of the night. We turn our scene lights on, which just illuminates everything to that side so we can have a good vision as to what's going on. With that, don't forget to turn them off, especially your rears, because you're going to blind everybody behind you. So check yourself on that. Check the operation of the heating and air conditioning of equipment, especially this time of year, making sure your air conditioning works. Your air conditioning up front is separate from your patient compartment, so making sure your air conditioning up front works, making sure your patient compartment definitely works. If you go to a hyperthermia, you don't have a working AC, that's not helping you or your patient at all. Communications equipment, making sure your radios are working. Our radios have 2 sets of antennas. Sometimes they fall off. If you're trying to hail to central or to your office and you can't communicate with them, check to make sure your antenna is actually there. That can definitely affect it. Your portable radio, your cell phone, all your forms of communication. Backup cameras. Most ambulances have backup cameras now, making sure your backup camera is operational, not damaged, and it's clean so you can see everything behind you. Returning the ambulance to your quarters. While you're backing up, have your partner note whether the backup alarm is operating, so you need a functional backup alarm. What I will say with this, anytime you back the ambulance up, you should always have a spotter behind you. Ambulances are heavy, you don't want to back over something or someone. So always use a spotter when you're backing up, use your backup camera and mirrors. Inspecting the patient compartment. Using your checklist, conduct a detailed inspection and inventory of the equipment and supplies. So Derek, do you mind, or Joe, grabbing one of our rig check sheets?
No, grab it.
Show them what it looks like.
I guess terrible.
Terrible. So checking your treatment supplies, so making sure you have fluids, oxygen, all your medications, making sure they're not expired. Interior equipment, testing your oxygen cylinders. Oxygen cylinders do develop leaks, so crack them, making sure you have good pressure, making sure there's no leaks, whistling air, that kind of stuff. Examine your rescue tools for dust, rust, dirt, grime, all that stuff. Just remember, you're going to somebody's house, they don't want a stair chair that's full of blood or dirt or that kind of stuff, because they're not going to want to sit on that. batteries, so power load stretchers, pretty much every stretcher is a power load system now. So it works off of a battery. If you have a dead battery, good luck picking that stretcher up with a patient on it. Carry a backup battery with you.
Do those charge while they're like in the truck?
No.
No, they have to be at a
Some
charging
systems,
station.
some systems do have that, but they're,
Yeah, because I think
most don't because it's quite expensive.
the
It's pretty
Furno,
expensive.
I think Furno has one where
Yeah.
it'll charge in the truck, but
Yeah.
they're
And
not
our Strikers
popular.
version, you gotta have like the whole entire like power load, like self power load system, and I think right now it's like 50 grand extra onto a truck for them. 35 grand, 50 grand, something like that.
Any guess
so.
as to how much not the power load or anything, just a power stretcher, how much a power stretcher costs?
Wait, hold on.
20,000.
Did you say 10 grand?
25,
50.
40.
30.
No, they're about 20 right now.
Clint just priced them for 30.
Oh, they've gone up even more. Jesus, they used to be 10.
Just the stretcher.
Yeah.
Damn inflation.
Just the stretcher to go up and down.
Yeah, we just had ours
Yeah.
repaired and I just asked them how much they were. This was a year ago, so it was about 20,000 a year. Wow.
They're
Just like a
expensive.
drill
Yeah.
type
Yeah.
thing, just take
That was a
the battery out,
striker.
put it on the
Yeah.
tractor.
Just, yeah.
You just take a battery
So
out.
Stryker
put it on-
actually
Yeah,
has a
it's nice.
representative for the Northeast, and he comes
They're
out.
from Boston. DeWalt
Yeah,
batteries.
yeah.
Or, well, Stryker,
Yeah.
they're Stryker branded, but essentially the same thing.
Yeah.
We got ours used from Shazy, I guess it was. Or,
Yeah.
yeah.
It's actually really common to buy refurbed
Well,
stretchers.
it ended up in the lake.
Oh,
They were
Jesus.
going to get somebody and they accidentally went too far and all the electrical went in, so it kind of shorted out, so they gave it to us for free. Got
Were the
the
patients
repairs.
still on the stretcher?
No. It was a boat and they were getting too close.
Gotcha.
Yeah, they
That
got a
makes
little too
sense.
far, yeah.
Yeah, that would be good. So yeah, checking your stretcher, making sure it's good. There are some actually, does Richford still use a manual stretcher?
Yeah, our unit 2 has a manual.
Manual stretcher.
Yeah, we
So-
have one powered.
The one bonus to the manual stretcher, they're actually developed to be lighter, so they're not as heavy to pick up.
Battery doesn't die.
Right, your battery will never die.
It's got hydraulics too on it, so.
Right, yeah, it's locking hydraulics, so as soon as you let go, and actually with these stretchers, same thing, if your battery ever died, there is a little lever you can pull, so your lights can go up and down, you just have to have somebody.
Yeah, have somebody manhandle it. That's when the battery dies and you trying to compress those hydraulics manually sucks. Like you're like hand here, like so the hydraulic manual is no good.
Yeah.
But the other thing is the battery powered stretcher. I think it's like 50 pounds heavier than, or 50 or 70 pounds heavier than the manual. So when it dies and you have to carry it, it's
Yeah.
worse than the manual.
Those
so.
stretchers, so our powered stretchers are 150 pounds. They can hold up to 700 pounds.
Wow.
Yep.
Your battery's got the meter readers on them?
No.
Well, it's just a blinking light, green, yellow, or red.
Blinking light.
Yeah.
So that's why every rig check, that's the first thing we do, swap out batteries,
Yeah.
make sure we're good to go.
Make sure you got a spare.
Make sure you have a spare.
How often do you check that spare though? You put that in there too?
That gets rotated every day.
Yeah,
I was
too.
gonna
every day
say,
we replace them.
Yeah.
So,
Usually what happens is the spare battery goes to the
in.
stretcher in the morning and then we'll grab a new battery to go in there. So if
On the cab.
that spare battery was only half charged or something, we still have the full charged one, which theoretically should get you through,
the
you know,
shift.
a shift, half a shift anyway.
Yeah,
So.
depending how busy you are that day, how heavy your patients are.
Yeah, as I say, that the more heavy patients you put on it, the quicker the battery will die. So
Yeah.
if you put 500 pound people on it in a row, the battery's going to die a lot quicker than 500 or 600 pound people.
So, yeah, kind of load dependent. With these stretchers, the other thing, I think you guys covered lifting, appropriate lifting and all that
Yeah.
stuff. So
Mhm.
remembering 2-person lifts. Some situations you may have to lift somebody on your own. Obviously, somebody that's too heavy, you're using 2 people at all times. For your safety, protecting yourself, protecting the patient, that kind of
You
stuff.
guys always do a 2-person lift?
Yeah.
Good.
Yeah, I mean, perfect world, yes. But when the battery dies and you only get 2 persons, somebody's got to manhandle
Well, yeah,
it.
right.
Yeah, but yeah, like general, standard practice is 2 people on the end. Yeah.
Yeah.
So.
Yeah. Fire's great for that. If you ever call for fire for medical help, they're totally gung-ho to help you lift. Whatever you need.
They usually do all the lifting for
Yeah,
you.
literally.
Yeah.
Even when you try to help, they're like, we got it!
And I think it's something about getting your firefighter certification. You're given like super strength because they will move objects that I've considered to be immovable. You know, it's like, hey, those Jersey barriers, I need them out. And they're like, come on, guys! I'm like, they just move them. Like, so just one time they picked up we had the stretcher at the lowest position, and everything was kind of chaotic on scene. And 6 firefighters just without using the system at all, just picked up the stretcher and yeeted it into the truck. Like, so it's like, whoa, like don't like patient at all, just like whoa, like, and so I mean they got it, it worked, but
Save your battery, I guess.
Saves our back.
yeah, it was like, come on guys, you're whatever,
Power to them.
they're in. Like,
That's all that matters. So yeah, that's the main components of that. Other equipment, monitors, that's a big part of your care, making sure your monitor's good to go. We do a test every morning. The life packs actually do it automatically, where it will do a test at 3 o'clock in the morning, just to make sure it's good to go. Our Zols, we have to do a manual test, but we do that every morning.
The life packs have a manual test you can run too.
Yeah, you can, yeah.
And should.
You just open the lid and it'll run through diagnostic.
No, so there's actually, so the Zol, we have a connector we connect the cables to, and then we just like an AED, you hit analyze, it develops a charge, and then you shock it, and it'll tell you test okay or test failed.
Here, hold this.
Yeah, pretty much. It's just the Zols use a 30 amp or a 30 joule charge. The life packs use a 10 joule charge, so they wouldn't do anything to you.
Yeah, you don't actually have to hook up the life pack to anything. You just hit user test and it does it on its own.
Yeah, kind of handy. So see that an item by item inspection for everything carried on the ambulance is done with findings recorded on the inspection report. So I will hand this out to you guys. This is our daily rig check, front and back.
No, be honest. It's not our daily recheck anymore. It's a
It has
bi-monthly.
recently changed. So now we're doing the first and the 15th of every month. This has to be done for every truck. So we did a modified. Prior to the past month, this was done every day. So we just modified it because this is time consuming. This will take you close to an hour if you and your partner just hammer down and go through this. But
And that's in the mornings, it's not after every call. You have something different for like after every call for decon?
no, so after every call, it's basically decontaminating the truck and then just resupplying between you and your partner what
what you
equipment
used.
got
Yeah.
used.
Okay.
But yeah, we just found it kind of redundant to write the expiration dates
Right.
of stuff every single
Hydrogen
day.
peroxide
like-
expiration, like,
Yeah,
that's
like-
not going to change anything.
And if you have 22 4x4 gauze pads versus 24, probably be okay. So kind of stuff like that. Like,
Well, probably doing it twice a month, people are a little more thorough than if it was.
yeah, well, and that's the thing. Is like we all go out. It's like everybody check your truck, and then the final 2. It's like, come on, everybody, check these 2 trucks. We go through and get it back up to that standard.
And we use a tag out system as well. A lot of services are using that now. So basically, you have these tags, so you can tag out the next expiration date on your bag or your first in bag or whatever.
Yeah, because some of the stuff like the endotracheal tubes will expire in like 3 years. So it's like, well, I mean, we've got them all. So
They also tend to expire in the middle of the month on random days.
I know.
yeah.
Unlike anything else in the medical service, it's either the first of the month or the last of the month.
Yeah.
Except for ET tubes, they decide sometimes they want to expire June 17th, and then the next one you get will expire October 2nd.
Yep.
I don't know why they do that, but
I don't know either.
Must be so many days from when they're manufactured.
Yeah. Probably.
yeah, but it's like that for the drugs too. But they usually just do first or last of
Yeah.
the month. I've never seen a drug that has
In the
middle of the month
Yeah.
for an expiration.
Yeah. So this is our rig checks that are going around, just to give you an idea of what a rig check sheet looks like. It's pretty dense.
Yeah.
There's a lot on here.
Yeah,
There's a
so
lot, everything.
so the state of Vermont requires that an ambulance be equipped with like this minimum standard equipment, and they have their own like sheet. So when they come around and do an inspection, it has to have like X, Y, Z. So that encompasses the minimum standard and above, like because
Anything in bold is what's
anything in
required by
bold
law.
is
Yeah,
a
they show
required
optional
thing.
in there.
Yeah.
in the book, so,
So, like hydrogen peroxide, that's not a state thing. We don't even use that for anything. But it's on there. Like,
It's on
that's good to get blood out of your clothes. Is what that's good for.
Pretty much. Disinfecting.
yeah.
So yeah, you guys will see that. That's going around. And another thing is liability-wise, if anything ever came up, you got sued for whatever. Let's say you were on scene to a cardiac arrest and your monitor malfunctioned. Well, the family sues you because you didn't have appropriate equipment to care for their family member. This rig check sheet will say, okay, at this date and time, we did a load test on that monitor, and it was operational at that time. That covers your ass, right? So, take that with a grain of salt. That's why we do these rig checks. Cover you and make sure you're prepared for your calls.
Who's the overall overseer of the checklist?
So we have a supervisor for that, Steve.
Yeah.
He's in charge of equipment and ambulances, reordering supplies, inventory, that kind of
And he
stuff.
stays on each crew every
Yep.
day and makes sure you do.
So
Turns them in and reviews them.
each day has its own supervisor.
Yeah.
So like I'm supervisor of A shift, which is Mondays and Fridays. So I take in all my rig check sheets from my crews that day. I go through them to make sure they were done. And then after expiration dates, that goes to Steve, so he knows when to reorder that
Start
stuff.
ordering.
Yeah, and our daily check at this point is kind of degraded to like, it's pretty quick. Now it's like, do I have a monitor, do I have a stretcher, do I have the red bag, do I have the green bag, do I have suction, how's my oxygen in my truck, just kind of the essentials. We're not doing the, what's the date on the mortar?
Just looking at that, trying to go and see where everything is in the truck and know exactly where it is in an emergency to grab that. And you've got nasal airways with like 20 different sizes. And,
Right.
Yeah. Okay.
So yeah, and that's why we have the tag system too, so that way if we're doing our check and we see that something's not tagged, all right, well, we gotta go through that and make sure that everything's.
So you don't want to see it?
No,
It's not
no.
tagged.
Got a letter.
Expired.
Thorough.
A few years ago, and I don't remember who I saw down here when it happened, but I was coming off Fairfax Street and there was a bag, so I stopped and grabbed it and came in and knocked on the back door.
That was 3 years ago.
Sounds like you remember.
Was that you,
That
Gary?
was not me.
Knocked on the door, I was like, I
There's
got
a
some
crew,
med
they
bag.
had a overdose, cardiac arrest, and they left the red bag on scene.
Okay, so they left it, okay, I figured they
And
left
they
it
went
on like
back
a
for it,
back
and the
buffer or
family
something.
completely denied that they ever saw it. And so all the equipment was out of it, and it turned up down the road.
Oh, no shit. Oh.
Good old
Oh, I didn't
Salem.
realize all that.
I left a green bag on scene one time. It was Andrew Dunsmore and I. And same thing when we got it back. They're like, oh, we found this bag. It was completely empty. Like, the oxygen tank was in it. Everything else was gone. Like,
That's why we lock our trucks on every call we go to.
Wow.
Because people will go through and steal your
Saint
stuff.
A, baby.
A bunch of scavengers.
So yeah, don't leave your equipment, and definitely don't leave your truck unlocked.
There's a fridge in the back of that?
Yeah.
Gotta keep your beds cold.
Put 6 packs of
Soda.
Holds one bed.
Holds one bag, yeah.
And
Alright,
some bottles of
so
wine.
that's that.
That's what I saw.
and my yogurt.
So think about it as I walk around the vehicle, engine on and engine off check. What information do I get from what I hear, see, and smell? Basically, is your truck functional? Are you operational? Are you ready to go on a call? If anything quirky looks out of place, or you're seeing fluids pooling up under your truck, or you're hearing abnormal noises, or seeing something that looks off, that's why we do this. Making sure we're operational for the next call.
Is your bays, so is that a ventilation or
Yeah.
go outside?
Yeah, we have ventilation systems in there. We don't run the trucks inside the bays. Anytime we're running the trucks, we're pulling outside.
Yeah. Yeah, that's good. They're kind of like, we do our little circle and check the fluids and all that. Then when we check the patient compartment and stuff, we pull the truck outside and leave it high idle, just so it kind of warms up, charges everything up, and
Yeah, that's a big thing. When you're doing your checks, diesel engines, they don't like to just start and go 100 miles an hour down the road. That's not how a diesel engine loves to work for a while. So anytime we do a check, pull the truck out, let the engine warm up. And while the engine's warming up,
Do you
your
have some
checks.
diesels?
They're all diesels.
all diesel.
Yeah. Every single truck's a diesel, even the van.
Is the garage heated?
Yep.
Okay, that's good. Because otherwise winter might be a little bit.
Heated and cooled.
Yeah, truck 2 does not like in the morning.
Yeah.
Like when you're first coming on shift, you're like, "Come on, baby!" Boom! It's like, all right, we're
We're
good.
good.
Like they gotta let that warm up. Yeah, like
Diesels are a bitch in that.
yeah.
Do you guys have exhaust vents in your bays?
We don't have, not like
Not-
the traditional
yeah.
sense,
Not
but
like the
truck,
connectors.
both bays are vented to
Oh,
Right. Some services have an actual connector that goes right to your exhaust,
Yeah.
and then as you leave, it disconnects.
That's what,
South Burlington Fire and Rescue has that.
Most fire departments do.
Yeah.
Wayne
It's
does
got a
have
cool
that.
system, actually.
Our fire and ambulance both have that.
Yeah.
Although I don't think the ambulance, does the, I don't think the ambulance uses
the
theirs.
ambulance does not use theirs because Michael says it's too much work.
Too much work.
Really? Doesn't take much to get out.
Carbon
pass it back
monoxide,
and get
what's that?
it up to the exhaust. You can do it while it's
Yeah.
moving.
Kick it on.
I'm gonna refrain
It's all
my
good.
hand upstairs here since it's recorded.
Okay. Yeah, because I want to
I
get
can
to those
delete that
trucks.
part.
So, do that now.
Do you wanna do that now since you
Yeah,
just
let's
talked
do that
about
now real quick since we just covered it. So we'll go check out the trucks real quick and then we'll come back and do.
I got these flats like last week, and they are pinching so bad I have not on my socks. They're just pinching on my feet.
Getting there. Sorry, that's long. Okay. Receiving and responding to calls. So how we operate the ambulance when we're responding to a call and when we're transporting a patient. So role of emergency dispatchers. So their primary role is to ask questions of the caller and assign priority to the call. We don't use a CAD system up here, so they don't really assign priority. Systems that do have a CAD system, they will actually assign a level 1 call, 2, 3, 4, which is basically somebody calling for ankle pain versus somebody that's in cardiac arrest. That's CAD system based. For us, it's just a dispatch of a call. So I need a unit to respond to this address for this reason. So dispatch will provide pre-arrival medical instructions to callers and information to crews. So if a cardiac arrest occurs, dispatch will call to or talk to the bystander and say, hey, check for a pulse. Are they breathing? No? Start CPR. They will instruct whoever called to start CPR for them. They'll provide us with information, so nature of the call, and then a general age and gender for the patient we're looking for. They also obtain dispatch and coordinate EMS resources. So do we need fire, do we need PD, that kind of stuff. Other public safety agencies. So the questions that they typically ask: exact location of the patient, that's kind of important. A good callback number for them, ongoing issue, how old the patient is, their gender, is the patient conscious, and are they breathing? So they just ask a very narrow, broad spectrum questions so they can relay it to us. So when we're operating the ambulance, you need to be physically and mentally fit. You can't be fatigued. You need to be capable of driving the ambulance, so nothing that can obstruct your operation for the ambulance. Perform under stress, so we're operating at a high rate of speed. We're in narrow alleyways, we're in busy roads, busy intersections, that kind of stuff. Bad weather, we have to go to it all. Have a positive attitude about your ability as a driver, but not be an unreasonable risk taker. Okay, so in the old days it used to be aggressive style of driving. Right now we use a defensive style of driving. So you assume that basically you don't know what traffic is going to do. Traffic never knows how to react to lights and sirens, right? So assume that somebody's going to pull out in front of you. Anytime you go to an intersection, we stop at the intersection before we proceed through, because oncoming traffic, they may not see you or hear you, and they may blow right through it and collide with you.
That's how I ride my bike.
Right.
Don't trust anybody.
Use a defensive style of driving, because if you get into an accident, now you have a crew that needs to go to you, and you have a crew that needs to go to your current patient, right? So be careful. Be tolerant of other drivers. Never drive while under the influence. That's a obvious given. So don't be under the influence of any substances. Never drive while taking prescription medications that can impair your ability to operate a motor vehicle. THC, alcohol, methamphetamines, that kind of stuff. Depressants. Never drive with a suspended license. Always wear glasses or contact lenses if required for driving. I always wear my glasses when I'm driving the ambulance. Evaluate your ability to drive based on personal stress, illness, and fatigue. So if you're fatigued, you're seeing double or, whatever, if you're not fit to drive the ambulance, then you should not be operating the ambulance. Understanding local laws, state laws. An ambulance operator must have a valid driver's license and may be required to complete a driver training program, EVOC, depending what service you work for.
And that's service dependent too. It's not state law that you have to have EVOC. It's just service dependent.
Yeah. Privileges are granted under the law to the operators of ambulances, apply when the vehicle is responding to an emergency call. So some privileges to us, per Vermont state law, we're allowed up to 10 miles per hour over the speed limit. Speeding above the 10 mile per hour limit, you can be pulled over, you can be fined. And that
Yeah,
kind of
the
stuff.
law doesn't, it doesn't specify a speed, but it says operate with due regard.
Yeah. Is it
So
our
when
policy
you
10
start
miles per hour?
driving, in excess of 10 miles an hour above, it's going to be hard to defend, that you were operating with due regard, but, yeah, so.
Well, I mean, it kind of depends on where you are, like, coming out of Venusburg, headed towards Sheldon, that's a 25-mile stretch, a 25-mile-an-hour zone, all the way past sticks and stuff.
Right.
I mean, you can be doing 50 and still be
Oh,
operating
yeah, it's
safely.
like, 105 is pretty
So,
straight and it's
yeah.
like built
Yeah.
to, so
Right.
it's,
Just keep in mind that if you get into an accident, they're going to look at
Oh, yeah.
how fast were you traveling in this zone, and
Yeah.
all that kind of stuff. So, just
So
be
is it
careful.
is it AmCare's SLPs or SOGs for 10 miles an hour? Is that-
that's ours,
If you're
yeah.
responding to a call,
Yeah.
if you're not responding, then it's speed limit.
And as far as transporting,
Transporting, same thing.
10 miles an hour.
Are AmCare's brakes capped?
Like as
Governed.
how fast they can
Yeah.
go.
no,
I don't think
not
so.
as far as I know.
As far as I know. I've never
they-
tested it.
Venusburg's
I haven't tested it, but I've gone
Oh,
pretty
really?
fast.
Dares Yeah.
Venusburg's rate is governed at 85.
Yeah, I know the old truck six would do above that.
Yeah.
So
Brakes not self-incriminating.
I do. Yeah. Now our Samsara will start yelling at you if you exceed 78. So it'll be like, beep, reduce the speed, and you're like, shut up. But yeah,
That's how
so-
it emails you too.
Yeah, so the system, like, it begins tracking, I mean, it tracks your speed all the time, but it starts logging speeding and categorizing it when you go 1 mile an hour over the posted speed limit, and it will categorize it into light,
Light,
moderate, heavy,
heavy.
or extreme, or severe, I think of it. So it's like, and it will, your trip will be like, okay, like he went from Northwestern to UVM, and during that time, he had 2.5 minutes where he was going 25 over the posted speed limit, and that calculates that as extreme, and eventually that will, one of the supervisors will be like, hey, what's going on here? Like, so, yeah. So it's kind of it's policed within the, within our service, so.
Yeah. So understand your local laws, privileges that are granted to you. If you're not on a call, you're just everyday traveling, you go under the same laws as any other driver. Okay.
One thing I just mentioned, I call it our kryptonite. So we're, with the lights and sirens, we are requesting the right of way, and state laws, you're supposed to pull to the right and stop. School buses with their stoplights on are our kryptonite. We cannot pass them, like with our lights on or anything. If they got their lights on, they supersede our lights. We have to wait till they shut theirs off. Usually pretty good about it, but that's why I call it our kryptonite.
Yeah.
So,
Yeah, school bus with their lights on, never pass them.
yeah.
no matter
I feel
what.
like most of the bus drivers, assuming they see you
Right.
behind
Right.
them, will be like, sit down and shut their lights
Yeah.
off real fast.
Yeah, I haven't run into an issue where I'm like waiting for kids to cross, like, come on, like, it's never been a thing.
Yeah.
But yeah, that's the one thing that we don't,
Right.
they
trump us.
They trump us.
So again, understanding law, even though certain privileges are granted during an emergency, the exemptions granted do not provide immunity to the driver. So because we're running lights and sirens, that doesn't provide us full-blown immunity. If we get into an accident, 9 times out of 10, it's our fault.
Yeah.
So anytime you go to court, that's what they're going to look at. If you blew through an intersection with your lights running and a car collided with you who had the green, I don't have immunity and I can't be sued for getting into an accident with that individual. It doesn't give me immunity. I can still be sued for that.
Because the other thing is you're the card-carrying professional driver now,
Right.
you know, like, and you're using lights to supersede the safety signals in the road. So now somebody T-bones you. It's like, well, you technically shouldn't have even been there, but.
Isn't fault for outside crashes determined on where the vehicle hit?
It can be, yeah, because
Is that rule of thumb?
rear end collisions, like if you rear end somebody, that's your fault.
It's
Like,
always-
it's
always
always
your
your fault.
fault.
So,
Yeah, I
like,
thought with broadside, if it is in the front half, it's your fault, and if it's in the back half, it's their fault.
it's
Is
something
that right?
like that. Yeah, I don't know.
Yes, but it's probably not gonna necessarily fall down those lines with
Right.
responding to a scene.
I would say it's situation dependent, because if I completely blew through a red light, even though I was running my lights and sirens, and somebody had the green and hit me, it's my fault.
Yeah, and especially intersections, because like technically the way you're supposed to clear them is you're supposed to come to a complete stop, make eye contact with all the operators, understand that I'm going, and then go. So if you especially with Samsara, if you're cruising through, you don't even touch your brakes and you just and then something happens, that's all going to be recorded, and then they'll see that you didn't properly clear that intersection. So. I mean, do we come to a complete stop every time? No. Usually it's a kind of we slow roll it, and so you come up, you're like, yeah, everybody go.
California style.
Yeah, California roll.
So yeah. Use warning devices in the manner prescribed by law. So we've already talked about this. Most statutes allow parking wherever necessary as long as life and property are not endangered. So if I'm protecting a scene or whatever, an accident that's on the side of the road, and I park my ambulance behind that and block traffic from going through that section, I'm protecting the patient, bystanders, that kind of stuff in that situation. Up on the interstate, we park our ambulance behind the vehicle, and then usually fire will park 100 feet behind us. They'll stick a big apparatus behind us.
I'm just going to Google real quick.
There's a
it's-
picture in the book.
Yeah, the Tim's model is say this is the motor vehicle crash. You got
Yep.
cop car
Yep.
up here alerting everybody, then you got fire truck and ambulance there. So that's the perfect world scenario. The apparatus is supposed to be blocking the scene. So if somebody slams into the side of the fire truck, it's heavy enough to where people should bounce off essentially and not kill everybody over here.
So use proper positioning of your ambulance to protect yourself, protect the bystanders, and most importantly, your patient. Proceeding past stop and signal signs. So like Derek said, making eye contact with everybody before we go through an intersection. Exceeding the posted speed limit as long as life and property are not endangered. So responding with due regard. As long as you're not putting yourself, your patient, and other bystanders in harm's way. Another thing I will say about speeding, especially if you're transporting a patient, if you're bombing down 105 at 90 miles an hour, be the person in the back of the ambulance. It sucks. If you're sitting on a bench seat, you're not forward facing. Every time there's a corner or a bump or whatever hitting the brakes, you're being tossed around back there, and your patient's being tossed around back there. It doesn't do you and it doesn't do the patient any good with excessive speed. It really doesn't help.
Yeah.
It doesn't buy you that much time.
Yeah, lights are for priority, not speed. And the old school driving instructor, the ambulance thing is we get in the ambulance. I take my coffee, I set it up on the dashboard, and I go, don't spill my coffee. And because that's when you're taking turns and stuff, you have to do if you just rip your turns, you think your partner's in the back, I'm starting an IB, so it's you got a lot. That motion transfers to the back of the ambulance a lot.
Right.
So
And it's 10 times more in the back of the ambulance than it is up front.
yeah.
My dad did that coffee thing when I was learning how to drive.
Yep.
I was so mad at him for it.
He'd probably be even more mad if he got coffee on him.
Yeah, true.
So.
She said,
Passing other vehicles in no passing zones after properly signaled and taking precautions. So vehicles pull off to the side, we can pass right by them. Most people are pretty well abiding by that. They'll move over for an ambulance. You will get those people who just completely ignore you for a stretch of a mile. Frustrates the hell out of us. Don't just weave around them. and put oncoming traffic in danger, making sure you have the right opportunity and the right moment to go around.
You have an air horn?
We do.
Oh, yeah.
Doesn't mean it always works.
Okay.
Some people don't care. Disregarding regulations that govern direction of travel and turning with proper use of caution and signals. So at some intersections, like Interstate Access Road, there's actually a median separating 2 lanes of traffic. Sometimes if your lane is completely blocked up with traffic at an intersection, you can take that opening on the opposite side, as long as there's no oncoming traffic that you're going to hit. Interstate, are we going the opposite direction on interstate? Hell no. In no situation whatsoever are you going in the opposite direction. Never, ever, ever do that. Because at the rate of speed that traffic is coming at you, they may not see you in time, and they're traveling 70 plus miles an hour towards you.
140 mile an hour impact.
Take the U-turns, take the time to go around. Never go on the opposite direction on an interstate. So our warning devices, we have the siren. Never use it indiscriminately, so if you ever take EVOC, they will tell you when you're approaching an intersection, 200 feet before the intersection, you're engaging your siren. When you reach the intersection, you're switching over to another sound. Typically it's a wail or a yelp. Just that change in tone can get somebody's attention. So that's why we flip between the different tones.
I usually like have a little song that I play with the, just with the tones. Like I have a particular pattern that I do, but
You would have a song to it.
it's a little,
I'm not surprised.
You hear that? That's Derek driving.
You can tell
I guess
it's
I've never noticed what you do.
Yeah, because I'm always I'm wailed. Then as I approach the air, like 200 feet, I switch it to yelp, and then I phaser 2 blasts in the air horn through. Like that's my pattern.
And I mean, use your siren as appropriate. If it's the middle of the night at 3 o'clock in the morning, there's no traffic, there's no reason for me to be blaring on my yelp and air horn, attracting attention to us and waking everybody up. There's no reason for that. So use it as appropriate.
Yeah, there's a service up our way that is pretty indiscriminate
It's 3 a.m.
on
That's
time.
my ex-wife's
For the
house.
people. Their siren and speed.
I don't drive at night.
At about 2 a.m. that clips on her. Find them.
Awake now.
But it's Timmy.
Yeah, I can tell exactly who's driving.
It's probably Timmy.
I can tell exactly who's driving when I wake up at 2 a.m. and I can hear him going down Main Street. And I'm like, okay, I know there was less than 2 cars that entire mile.
I've done that down Main Street here. 6 o'clock in the morning, get me out of bed. If I'm up, you're up.
The hell with you.
Now we know who the asshole is.
So yeah, using your lights, day or night. Some services have an option using secondary lights versus primary lights. That's just basically using your bright white lights versus just red lights, that kind of stuff. So some services have the difference between
When it's snowing out, sometimes it's better to shut your white lights
lights
off.
off. Yep, definitely.
Yeah.
Just with flashback and stuff. Vehicles should be easily seen from 360 degrees in emergency response mode, so make sure all your lights work all the way around. Speed and safety, excessive speed increases probability of collision. So the faster you go, the more likely you are to hit somebody. Your braking distance increases quite a bit. And people seeing you, they may not see you as quickly with excessive speed. So increases stopping distance, reducing the chance of avoiding a hazardous situation the more you slow down.
Yeah, and just one thing, I don't have exact statistics, I think, but as far as we don't have the same occupational hazard as firefighters going into burning buildings or police officers dealing with, violent individuals for the most part. But our biggest risk in this job and what kills most EMTs are vehicle crashes. That's how the majority of EMTs get killed in this line of work. Yes, so it's
That's with firemen, it's not in.
yeah. So so just keep that in mind. That's the most dangerous part of your job.
It's just a physical operation of the ambulance. Escorts. So escorted or multiple vehicle responses. Inexperienced ambulance operator often follows the escort vehicle too closely and is unable to stop when the lead vehicle brakes hard. So if we send 2 ambulances to a call, we've got one following behind the other. Inexperienced drivers sometimes will follow way too close to that first ambulance. They can't see that they're braking hard for a pedestrian or an oncoming vehicle or anything like that. So keeping your distance. We don't ever really use police escorts. I can't. You have? I've never used. Yes, I have.
I got one on a transfer of a subject, and Sounds PD escorted us all the way to UVM.
I can see that.
Cool.
Yeah, the only time I ever had one, it was when I was on Grand Isle. It was 8 o'clock traffic going to Burlington, and there was an accident ahead at like exit 16, and we actually had a South Burlington PD officer escort us through traffic to get us to UVM. Had he not have, we'd have been stuck in that traffic for an hour. So that worked out. Just keep in mind with that, keep your distance from your escort if you ever do use one.
What's the theory on that? They move for blue lights?
Yeah,
here
people
for red?
people tend to respond to blue lights a lot
They'll
more.
pick up seeing blue lights faster than they will red lights.
That's why the whole bill passed this year, allowing fire trucks and other emergency responders to put different colored lights on their vehicles.
Yep.
So fire trucks can have a blue light on scene and only on scene. You
Yep.
can't run with it. And ambulances too, because
But
they're,
not personal vehicles, right?
you may not have it in your personal vehicle. But it was, I mean, that percolated for almost 15 years because
The
people kept
police
getting
union, the police unions didn't want it.
Oh, I'm very aware.
God forbid.
Yeah.
Makes them
That's our
special.
Yeah,
Actually,
one light on a truck is not going to make people
They
think you're a police
really
officer.
tried to make a purple light instead of a blue light. I cannot tell you the nuance in that
Purple,
discussion.
really?
Just.
Should have told them to grow
It
up.
was probably 2 weeks of testimony on purple versus blue and the effectiveness.
Oh my god.
Yeah.
Yeah, I can't see using both.
There's a subject
But the
matter
funny thing
expert
is,
on
you go
light.
right next door to New York State, and volunteer firefighters and EMS use blue lights in their personal
Mhm.
rigs, and cops use red lights.
Yep.
Yep.
Yeah, volunteers have green too over there.
Yeah.
Yes, green, or blue.
Yeah, I got pulled over by a New Jersey state, and it was red lights.
Yes.
And so I was like, oh, good. Oh, he's behind me. Shit. Huh?
That's not a fire truck, that's a cop.
Yeah, because I was like just letting him go, and then he's like right in behind me. I was like, oh.
Yeah. Every state's different like that too, so it's just like,
Yeah, be aware of the state you're working in.
Yeah, apparently you're
Driving
supposed
through.
to dim your high beams before a toll booth. I didn't know that. No.
that's what he pulled you over for?
Yep.
He must have been having a really boring night.
Yeah. He let me go. He's like, you didn't know that? I was like, we ain't got these up where I'm from. He's like, where are you going? And I'm like, Virginia. He's like, south. And he just left. And I was like, thank you, sir.
Were you in an ambulance?
No, I was in my personal vehicle. Like,
No, it's,
Keep going.
yeah. There is a service that long before the law changed this year ran with a blue light.
Albert.
And
Williston. Williston, Colchester.
Albert has it because they actually do some calls over in Rouse's Point,
Yep,
so they have the blue light for that.
yeah. But they take it every inspection right before they come up, change out the bulb.
Oh,
Back
really?
to red.
Yeah.
Because they're so UV.
Right.
South Burlington has it.
Yeah, no, South Burlington was the push for the bill.
so one thing about the like multi-vehicle thing and intersections, most people, so, you know, we're kind of unique where we're like sending 2 ambulances to a call, you know, on a lot of stuff. So when you're coming up an intersection, most people aren't expecting to see 2 ambulances, so they hear the wee 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 and the ambulance go through, then they think, you know, they can still hear it. They're like, oh, we're all clear, and then the next one comes up. So if you're in that second vehicle, clear your intersections as if there's nobody in front of you.
Yeah.
So,
Yeah, good point.
If I can add to that, also, like, if you're coming up to a line of cars and there's like 3 or 4 cars in front of you that start pulling over, the cars in the middle might not know. Like, the car in the back might see your red lights, and the car in the front might have pulled over because they saw you. And the car in the middle might be like, oh, why are we pulling over?
That happens
and
all the
then
time.
dart out.
mhm.
It's happened, yeah, I mean,
Yep,
that's happened.
that happens all the time.
Dozens
You'll
of
see
times.
people pull around them and you're like, what the hell? So yeah, good point.
Yep.
Be aware.
I was in my personal rig one night and saw a town fire coming up Lake Street. I pulled over way ahead, and then someone tried to go around me. I literally stuck my head out the window with with a particular finger and said, pull your ass over.
Just a nice gesture.
Yeah, I use a nice gesture.
So, for your book and what we're teaching, the recommendation is no use of escorts unless absolutely necessary. So they can create a hazard, only use them as needed. Factors that affect response: day of the week, time of day, weather, road construction, railroads, bridges and tunnels, school buses. So particular day of the week, business day. If you're in the middle of business hours, people are at work, it's usually not as busy, but if you're during time when they're going to work or coming home from work, it's busy.
Yeah, like 4:30 to 5:30 in Burlington, like
Yep.
congested as
Sucks.
hell.
Can you pass a bus with red lights going?
No.
Right.
He just said that.
Oh, did he?
Good
Why
question.
you gotta ruin
I didn't
that?
say
We all
this.
just look super
Apparently I'm not listening.
Right?
I didn't say that, like, I think you're up there.
Yeah.
Oh.
Yeah, I just explained there are.
I'm glad they-
Well, you brought it up at a different point in the lecture. It's supposed to be right here.
It just made me think about it.
Gee.
So weather. Weather is a great point during the winter time. Our speed reduces quite a bit. Even some situations, if we're in the middle of a blizzard, we may not be going speed. We may be going less than the posted speed. So use discretion with that. If you're in the middle of a rainstorm or you're in the middle of a snowstorm, reduce your speed down. Reduce your risk of getting into an accident. Road construction, if you're coming up to a road construction site, don't just bomb through the road construction site assuming you have the right of way. They're holding traffic on each end. Wait for them to clear you to go through.
They'll let you go pretty fast.
They're
There's a
usually pretty
flagger
good
for a
about it.
while.
Unless there's cars in the middle that are coming through, then they'll tell you to stop and wait. But listen to them, because that's going to prevent you getting into the accident.
It's actually protocol for the one that I was working for anyway. If we see an ambulance with lights on or any vehicle
Yep.
for that matter with lights on, just stop and let them through.
Yep, absolutely. So pay attention to your road construction crews. Railroads, what do we do if we're coming up to a railroad section and there's
Open the doors.
always, yeah, you don't have to open
Windows.
doors. Right, open your windows, listen, check for the signs, make sure they're not flashing. If there's a train going through and we're stuck at a railroad, what do we do?
We're gonna wait.
Wait. Unless you by
Beat it
chance
by going
have
to the next
another
street over?
unit that can come across, you gotta wait.
If you do, it's a good idea too. Like I will get on the radio to dispatch to and have
Yeah.
them mark a response delay.
Yep.
So it's actually marked that way. If there's ever any question of like, oh, you took an extra 10 minutes to get here from just around the corner, it's like, well, because of the train, now there's a logged incident of, yes, we were delayed due to a train and there was no way around it.
Keep it on record, that's a good point.
Yeah. And then obviously document in your run report also.
Yep. Bridges and tunnels, we don't have that many tunnels around here. We do have bridges, we have some narrow bridges, so slow down when you come up to a bridge, especially everybody's favorite bridge up by VSP. That's a very narrow bridge.
Yeah.
So slow down when you come to that.
Is there one up in Richford still like a jump?
Yeah.
Yeah.
Oh,
And I
yeah.
hit that in my cruiser one night, dude. Whoa, like I forgot it was like that. Yeah, I forgot it was like that. I'm pretty sure I missed the entire bridge. Like,
You all use a hazard on it.
You gotta hit that thing at like
What?
20.
I hit it in my as I was working for the Franklin County Sheriff's Office. I was going to back TJ up,
Oh.
and dude, I forgot and just like, oh shit, boom, like.
We see him driving the grooves that are just dug into the pavement there.
Yeah,
Those
dude.
have gone
Yeah.
too fast and landed too hard.
Yep.
Them Duke boys.
And it's not so bad, it's not nearly as bad from one end.
Yeah, I was coming farther
Yeah,
this
they're
person.
Coming
It was like,
from,
I say if you're going out of Richford, it's fine. If you're coming
yeah,
into
if
Richford,
you're coming
it's
into
awful.
Richford,
So if there's no one coming, I go to the other lane,
Yeah.
and come back over. And
Yeah.
the way it yells at me if you don't car.
Well,
Actually, at night,
it
you
was
don't
built that
say.
way on purpose. It was
Right.
like, if you're coming into Richford, it's like, wait, are you sure?
yeah, right. Welcome to Richford. Are you sure?
Sorry.
I'm still like the last month.
Oh, God. All right, so yeah, bridges and tunnels, slow down, school buses trump us. Wait for them to pull over before we proceed. And never pass them if their lights are on.
Are there still bridges, well, are there any bridges in the service area that are too low for the ambulance?
In our area, not that I know of. There's some in Montgomery. There's some covered bridges that you can
Yeah.
go through.
I'm thinking of the covered bridges, but
Should be able to fit through most of those.
yeah, there's some bridges the fire.
How's that one in
Yeah,
the
fire trucks are different though.
Yeah, we're a little
I'm
taller.
just asking
Yeah.
if
There's
there's
one
any-
bridge in Sheldon that we can't cross, I know that.
Because of weight.
because of weight.
Oh, yeah.
What's that?
That's changed though, that's all
What's that
done
one in
now.
Richford?
Not the one
Which
by,
one?
where
The one
Yeah.
in,
The one with the train tracks?
Were you thinking
over
the one
it?
at Highgate?
oh yeah, the one,
You were
yeah, the one,
thinking Macy Road, right?
yeah, that one's been all
That
changed
one's
out
done.
now.
But-
Right, that one's
Head
different
going through
now.
there
No, the one over by
a couple
Shea,
years
I forget
ago.
the name, Brigham Road,
I
or,
was running late to a
It-
showing and I just.
it's like a wooden.
It's over
Yeah,
by Rice Hill,
yeah.
it's on the other
Yes.
side of Rice Hill, Shawville.
This sounds
Isn't it Shawville Road?
Okay.
No, it's Boucher Road,
Yeah,
you're thinking of.
Boucher,
It's the other end of,
Yeah.
Boucher Road and Shaw, has a bridge that you
Yeah.
can't cross in our
They
ambulance.
actually
Yeah,
just
Shawville,
put
I
it
think
in
we
house.
can,
Type
we
two
can
Yeah.
make
Yeah.
it,
lanes,
but it's
type
like,
one can't.
it's one lane, like somebody else is coming.
Well, no,
Yeah.
they just bought and replaced. They're over on Dunlop Street now.
Does anyone know
Closed on
the,
Monday. Yeah.
the one vehicle that does not have to yield to emergency vehicles? Huh?
The president.
Well, yeah, but thinking of a different one.
Correction.
Postal Service.
Oh, postal service.
Those bastards.
Postal Service technically does not have to yield, like, it's a weird law that was written a long time ago, but nothing can stop the US mail. Nothing can stop the US Postal
That's
Service.
because
Not
they
raising
carry
the
higher
ballots.
postage.
Huh?
Part of that is because they carry ballots.
Yes, but it's a law that goes back a long, long time ago, but it's still technically on the books. But they technically do not have to. They obviously will because they're not jackasses.
Do you know
They're not
that,
all
well,
jackasses.
do you know
Well-
legislators can't be pulled over on their way to the State House?
Huh?
Legislators can't be pulled over on their way to the State House?
Yeah, which
But
is
jackasses who borrow
bullshit.
their cars can.
Yes.
I didn't know that. I would have think you're filling me full of land. It's like, you can't pull me over.
I don't think they should. But
Get out of the car.
No, it was used to delay a vote.
Yes, I know the reasoning why. I'm just saying.
So now if we're doing state business, you can't pull us over. We can still ticket us. You still
We gotta
have to
keep
pull us
cruising
over.
through.
Almost done.
I'll tell you the story after.
Response safety summary, minimize lights and siren, hot responses, driving with lights and siren involves high risk. So some services have priority responses, whether certain calls you use lights and sirens and certain calls you don't. Right now here in Vermont, any emergency call we go to is lights and sirens. Some states have it if you're going to a lift assist. They don't require you to use lights and sirens for those calls. Hopefully something we get up here. at some point.
Alex, we did that a little
Oh,
bit
really?
ago. Yeah, the tier drill, like,
Priority.
yeah, you had a priority 1 or a priority 2. A priority 2 was like, fall, lift assist, like very benign stuff. But
Yeah.
priority 1 was chest pain or anything like that.
This goes without saying, wear your seatbelts. Do we wear our seatbelts in the back of the ambulance when we're caring for a patient? Absolutely, always. Anytime that vehicle's moving, everybody in that ambulance needs to be wearing a seatbelt. It gets difficult, especially if you have a sick patient, so that's why preparing yourself, having everything you need right there with you before the ambulance leaves, and doing what you need to do before the ambulance leaves. Know where you are going before you respond, so pull it up on your GPS. We have tablets, we have physical books, and we can look up addresses so we know where we're going before we leave. I don't want to take off in the wrong direction. It's happened before.
Assuming you get dispatched to the right place.
Assuming.
Yeah.
I only had it once in my career where I got dispatched to the wrong address.
The other thing about the
It's
GPS, GPS is great, but we do have some like class 4 roads that connect other roads.
Yep.
So the GPS doesn't discriminate. Sometimes it'll be like, you're gonna get there 5 minutes faster if you drive down this logging trail. So it, just kind of keep that
Know
in
your
mind.
area.
Know your area. So
We had our ambulance in the middle of winter go up over Enosburg Mountain because they thought
Oh.
the GPS was
yeah,
taking it faster.
For a Jesus notch.
Oh,
Who is that?
I'll tell you later.
I'll tell you.
He's still in EMS. I'll tell you later.
Safety at highway incidents. So keep unnecessary units and people off the highway. Any care you're going to do, you're not going to do it in the middle of the road unless the road is shut down. Avoid crossovers unless a turn can be completed without obstructing traffic. Protect the scene if yours is the first unit on scene. So first unit on scene at an accident, we're going to protect the scene, park our ambulance behind, prevent traffic from going through until we can establish and keep everybody safe. Safety at highway incidents, wear your appropriate PPE. state law, we have to have some form of reflection anytime we're on the interstate. We have class 4 DOT vests, we are required, AmCare policy, we have to wear those vests anytime we're on any form of road incident, we have to wear those. State laws, you just have some, I don't remember what the
I think it's,
class
yeah,
is.
you have to have like the ANSI, like whatever, the rated reflective or whatever.
Right, I
But,
think it's
but I believe
class
it is a
3.
law, like
Yeah.
it's,
So
like
I
you,
believe it's OSHA.
yeah.
Yep.
um,
Yeah.
So
sure.
if you're on the job, you have to. If you are stopping to volunteer your services,
Yeah.
your knowledge, you don't have to.
Okay.
Because you wouldn't fall under OSHA at that point.
Someone was still
Right,
probably throwing
right,
it
if you're doing like a
anyway.
good Samaritan ordeal.
Yeah.
So,
If you don't have it, tell Dave St. Pierre to not take pictures of it.
And that's why technically Dave doesn't have to, because he's a subcontractor
Yep.
for everyone he works for.
Right.
And OSHA only qualifies for, I believe it's workplaces that have 7 or more employees.
Yep.
So he's a workplace of 1,
Yep.
doesn't need to.
He doesn't have to, yeah. Aside from being sued and stuff and getting in trouble, it's your own personal protection.
Yeah.
Wear reflection, especially at night,
Especially.
so people can see you. Place cones, flares, and reduce emergency lighting. That's more of fire that will set that kind of stuff up. We're not setting up road flares unless our unit is broken down, then we use cones and flares to deter traffic from us. Unit placement is important. We already talked about that, how you quarter your unit. You quarter your, typically your rear or your front out. I prefer my rear, so that way if I get a rear end collision, they're hitting my rear, not my front, where I could be. Backing up. Avoid backing up if possible, especially during emergencies. So this is a big thing. Whenever we go to a call, we're going to somebody's driveway. We're backing into the driveway. I'm not driving into their driveway. My partner at that time is not currently with the patient. They're going to back me into the driveway so that way I have an easy drive out of the driveway. If they don't do that, if you drive into somebody's driveway and you have no place to turn around, you're now backing out into traffic. That's hard to see, especially busy roads. That places you and especially your patient and partner in the back at risk. Backing into your
Not to mention it's time saving too. I mean, you never know why you're leaving. You know what I
Right.
mean?
Yep, exactly. So take the time, that's the time to do it. Back into the patient's driveway. And then avoid backing up without a spotter if you can.
Yeah, and I mean, if you have to retreat,
Right.
you know, if you are in a dangerous situation, then you can
Yeah.
just split. You don't have to back up. Like Liam and I were chased out, like down the driveway at one time, like, and we had pulled into the driveway. So like Liam's in the front, like go, 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 and he's running at us with his underwear, and like, so like, yeah, it was a good time. Like,
Quick getaway. Yeah,
Also,
so
we have winter stuff here too. You're gonna be damn thankful you back into that
Absolutely,
driveway instead of
a lot
pulling
of
into it.
driveways we go to aren't plowed. So I'd rather figure out I can't make it by backing up so I have an easy exit out. So if you send it into the driveway and you make it to the top, I've been stuck in driveways before. It happens. It's not fun.
Oh, fire department.
Or a tow truck. Yeah, pretty much. Transferring the patient to the ambulance. So select proper patient carrying devices, package the patient for transfer, move the patient to the ambulance, and load the patient into the ambulance. So you can see with this picture how the patient is packaged very nicely. They're bundled up in blankets, it's cold out, they're wearing, side rails are up, and all straps are across the patient.
That's an old school.
Did they
That
get
is
a
a
Very
hospital
old school
stretcher.
stretcher. What's that?
Did they get a cop to do some lifting?
Looks like it. Nope, that says EMT on the back.
Okay.
Just wearing a vest. So yeah, this is what all our patients should look like. Obviously, if it's hot out, we're not going to devour them in blankets and wrap them up, but they should be secured appropriately with all buckles you have on the stretcher and side rails up. Cold weather conditions, we're bundling them up. So ready the patient to be moved, combining the patient and patient carrying device as unit is ready for transfer. Sick or injured patients must be packaged so that the condition is not aggravated. So position them in the way. If they're experiencing left side abdomen pain, I'm not going to lay them on their left side. I'll secure them so they're laying on their right. Pregnancies, when we go into obstetrics, females that are pregnant or getting ready to be in labor, especially if they're sick, we'll lay them on their left side. So just different ideas to keep in mind. Before placing the patient on a carrying device, complete necessary care for wounds, other injuries. So before removing them, if we need to stabilize their neck, stabilize their back, head, whatever extremity, stabilize it before you move them, kind of makes sense. We don't want to move them while it's not stabilized and cause further injury. Impaled objects, once we get into trauma, we'll talk about this. Stabilizing impaled objects, we don't just pull it out. Somebody's got rebar through their abdomen, we're not going to yank the rebar out. We're going to stabilize it in place. Cover the patient and secure the patient to the carrying device using appropriate buckles. Pretty much talked about all this. So most stretchers come with at least 3 straps. You are required anytime during transport. All straps must be across the patient. Some stretchers have the 5-point harness, so the shoulder straps that come across. If those are part of your stretcher, you have to use them. If they're not part of your stretcher, then it's not a requirement, but if those straps are available, you have to use them. Protecting the EMT. So an EMT is at greater risk in patient compartment. So again, we're bombing down the road at 90 miles an hour. Your greatest risk for harm is in the back of that ambulance, especially if you're not seat belted. Ambulances do get into accidents. Your worst case scenario is you get into a rollover, you become a human dartboard if you're not secured down to the stretcher. So remain seated, wear a seatbelt and harness, avoid unnecessary movement during response and transport, and make sure all equipment is secured. So our monitors are secured, our bags are secured. So in the event we ever get into an accident, that doesn't become a projectile and fly to the forward or hit us.
And don't bug your partner when they're white knuckle driving.
Yeah. That's why anytime we respond, you've got one person in the passenger seat who's doing the navigation, calling out directions while the driver is paying attention to the road.
I was talking about being in the back. Don't bug your driver when he's focused on driving down the road white knuckled.
Yeah, don't do that. Transporting the patient to the hospital. So you're continuing your assessment. If you're in the back, secure the stretcher in place in the ambulance, position and secure the patient, adjust the security straps. When we did the EVOC course, one fact that I found interesting, any idea at what distance of travel somebody secured in a shoulder harness, if they're involved in a front-end collision, how far they can travel with those shoulder harnesses? You know? You remember?
Yeah, I was gonna let them answer. See if they answer.
Stop.
14 inches.
14 inches. So that patient is secured with the shoulder harnesses, and you get into a front-end collision, they will travel 14 inches up on that stretcher. So if you're sitting in the captain's chair, they're going to ram right into you, depending how far your captain's chair is from your stretcher. Keep that in mind. The straps are designed to, and they want that travel because if it was just an instantaneous stop, you're going to break your shoulders and ribs and all that stuff. So they want that travel to slow down the inertia. So something to keep in mind.
Wear a cup.
Wear a cup. Prepare for respiratory and cardiac complications. So that's something we're doing before we're transporting the patient. Obviously, we're reassessing if we need to intervene. You know, the patient's crumping, we'll pull over to the side, do what we need to do. I'll pull my partner in the back and say, hey, I need to intubate this patient, or we need to do some form of invasive procedure. I'm not going to try that bouncing down the road.
Was.
Yeah, wuss. Loosen constricting clothing, or maybe cutting off circulation. Load relative or friend who must accompany the patient. So we'll assist them into the back if they're going with. If it's a parent, we'll have the parent come in the back of the ambulance with us. Most cases, if they're riding along with us, they'll go to the front of the ambulance and secure up front. Load personal effects. So if we're taking any personal effects, we want to make sure they're placed away and secured so they don't become a projectile. Talk to your patient, let them know what you're doing. Anytime you're reassessing them, letting them know, don't just sit in a chair and ride to the hospital without saying a word to them. Unless they're sleeping or unconscious. Avoid letting patients sit on bench or airway seat. So not a lot of times, some of the times we'll have patients ask us, hey, I don't want to sit on the stretcher, I'd rather sit in that seat there. Our policy, any patient that's transported by us has to be on the stretcher. Okay, they can't be transported in the seat. Only caveat to that is certain sizes. So like infants, the captain's seat will actually fold down to fit an infant. It has an implanted car seat, or not car seat,
Yeah.
pediatric seat,
Pediatric
child
seat.
seat, so we can secure them right there. That's more or less if they're like with the parent, we're caring for the parent, we need to bring their kid along with us, we can secure them in that seat.
If you have like a number of patients and you're transporting two, and you have a walking wounded, can you put them in the?
Okay, yeah, yeah. So.
Yeah, it's not a like, hard stop, like
Right.
hell no, can't go thing. But it's just the safest place for the patient is on the stretcher.
Right.
So.
And even
it's-
if you need to lay two people supine, you can use that bench seat to lay them flat
Yeah,
as well and
yeah.
secure them. There's actually 3 buckles that will come across and
Yeah.
secure them right there. We don't advise it, but you gotta do what you gotta do.
Even on the new ambulance? Only 1 in 5? I thought they only have the 4-point harnesses in there.
No, they
for
still
us.
have the buckles down below that you can put across.
Guess
Yeah, I don't know if you guys.
Never
saw
had to
that.
go looking for them, so.
Yeah, we never use them, but they're there. Our new ambulances, any new ambulance that comes out, they actually come with 5-point harnesses in the back for responders. That's in 1 in 5.
Is that those red things where they were hanging?
Yeah.
They're actually pretty comfortable with it.
They
They're
are,
actually not
yeah,
bad.
I actually don't mind them.
I wear mine when I'm working with Dustin.
So when you're caring for the patient, you're en route, you notify the hospital that you're on the way, provide them with a report, so you don't just pop up on them and say, hey, we're here, and the patient's about to crump. Give them a heads up, let them know what's going on. Continue to provide emergency care, so even when we're transporting, we still provide emergency care. Use safe practices during transport, so minimize the amount of times you have to get up from the seat. It does happen from time to time, especially if you're doing chest compressions. You can't do effective chest compressions sitting down and pushing out somebody's chest. So, compile additional patient information, so on your way you can get more patient information, monitor their vitals, and notify the receiving facility what you're coming in with. Pediatrics. The entire scene may create a terrifying experience for a pediatric. They've never been exposed to an ambulance before. Now you've got these bunch of people who are pulling them and doing all sorts of assessments and that kind of stuff on them. It scares the hell out of them. Each ambulance or each emergency service has access to a toy. The Vermont Teddy Bear Factory partnered with Blue Cross Blue Shield, so they supply us with teddy bears that we can give to kids anytime we transport them. Sometimes the presence of a female EMT or an officer may be helpful. Again, situation dependent. If I'm working with Joe, Joe has a better rapport with the patient. Joe will run the call because he has a better rapport with the patient. Small children, as a rule, don't carry identification. Kids don't have personal identification. I think we all know that. So using caregivers and that kind of stuff. Transferring the patient to the emergency department. So in routine admission situation, or when an illness or injury is not life-threatening, checks first to see what is to be done with the patient. So a good rule of thumb that I use, the first 5 minutes you're in the ER with the patient, whatever the ER does in that first 5 minutes is something that you should have done in the back of the ambulance. So you're there, you didn't get a 12 lead, and the first thing they do when you get there is a 12 lead, you should have done one in the back of the truck. Okay? With that, obviously, if it's something we can't do, notify them that, hey, I think this is going on, and lead them kind of down that path that this is what I'm looking at, and go from there. So they can intervene right away with what they need to do. Assist emergency department staff as required and provide a verbal report. So a lot of times I'll help them out moving the patient over from our stretcher to the bed. If they need help, they're busy, I'll set them up on the vitals monitor. A verbal report, you can't just ditch and run that patient. You need to provide some form of verbal report to a receiving nurse when you get to the hospital. Some states require that you leave some form of written copy of your report. As soon as you're free from patient care activities, prepare the pre-hospital care report. We went over that in documentation. That's the report you file after every call or every patient interaction. Transfer the patient's personal effects, so any personal effects that you brought with you that are the patient's, make sure the patient is aware where you leave them, and also include in your report, your documentation, what you brought with you and what you left. A lot of times patients will call and say, hey, we brought my purse with me, where is it? And you don't have it anywhere documented, you're not going to remember it. They can go after you for stealing their stuff. Obtain your release from the hospital. Not sure what they mean by that. Okay. Terminating the call. Quickly clean the patient compartment while taking appropriate standard precautions. So after every call, we clean the stretcher, we clean the interior of the ambulance, put on new linens, replace our linens that we used, and then replace any equipment that we used. That's pretty much all that. So clean the ambulance interior. Joe loves doing this. So any soiled surfaces, spray everything down, especially during times of COVID. We clean the entire interior of the ambulance.
Nobody
Hospitals,
likes that,
I know.
except for Shay.
Yeah. The hospital actually provides us with cleaning materials, so right there they supply us with sprays and wipes and all that stuff, so we can use that. We also carry it on our truck for no transports. We can clean the inside of our truck on scene. En route to quarters, so you've cleared the hospital, you're headed back to quarters. Notify your station, notify your dispatch that you're clear and available. Air out the ambulance if necessary. So during COVID, we actually had to open the ambulance doors, let it sit for 15 minutes to allow good air exchange in order to decontaminate the truck. Same thing, if you have nasty smells, patient soil inside the ambulance, allow some time to air it out for your next patient. And then refuel the ambulance. You don't need to refuel after every call, but our mark is when we get to the half fuel mark, we'll refuel the ambulance. In quarters, place contaminated linens in a biohazard container and non-contaminated linens in a regular hamper. So anything that's soiled with blood, fluids, any kind of matter from the patient, that goes into a biohazard because that's dealt with separately from regular materials. As necessary, clean any equipment that touched the patient, clean and disinfect used non-disposable respiratory assist and inhalation therapy equipment. Clean and sanitize the patient compartment, prepare yourself for service. So kind of hurry things along. Partners work together to make sure everything's decontaminated and ready to go. So respiratory equipment, we don't reuse respiratory equipment. Anything that's used respiratory-wise gets thrown away. Blood pressure cuffs, disinfect blood pressure cuffs, EKG lead cables, that kind of stuff. Don't throw those away. So replace your expendable items, so anything you threw away, make sure you replace it, refill your O2, replace any patient care equipment, clean the vehicle, complete your paperwork, carry out any post-operation vehicle maintenance procedures as required, whatever your service requires. Terminating the call, replace expendable items as required, so he's replacing all his O2 stuff, a couple NRBs that they used on the call, so that we get ready for the next call. Alright, last part, air rescue. Yeah, we're over on time, I'm sorry. Air rescue. So, we do have an air rescue policy here in Vermont, when to call for air rescue, when it's needed, situations where air rescue may not be available. So, air rescue. Some reasons that we would call for them. One is to speed up transport to a distant trauma center. Coming from Richford, it can take you almost 2 hours to get to UVM, which is our level 1 trauma center from Richford. Not Dartmouth. UVM Medical Center, their flight team, it would take them almost 10 minutes to get to Richford. So 10 minutes versus 2 hours. And that's as needed. If the patient isn't critical, they will be stable enough to make it that 2 hours, then do that. The cost of a helicopter, any idea how much a helicopter costs?
Isn't it $1 million
$1 million.
baseline for a call?
Yeah,
Yeah.
it's $1 million. And not all insurances cover air medical. So, not that we transpose cost of healthcare for our patients, but use your common sense with that. If somebody's got an ankle fracture, a simple ankle fracture, I'm not going to call MedFlight to come transport this patient. That's not necessary. Especially, I'm pulling that helicopter crew from another call, right? Use your resources appropriately. So, if your patient's critical and they need to get to a trauma center quickly, then we use air medical. When extrication of high priority patient is prolonged, so elongated extrication, they're entrapped in the vehicle, then we can call for air medical. That would be a great reason too. Or when the patient needs to be rescued from a remote location. So you're out in the middle of nowhere, you're an hour from any close hospital. You can use them to extricate from particular locations if it's available. So patients are sometimes transported by air rescue helicopters. This is an example of life flight. They're out of Maine. Or no?
No,
No.
That's life
flight's
flight.
out of Albany. I believe it's Albany.
I don't think so.
I'm pretty sure.
Well, I mean, there's a lot of different life flights out there, so wherever.
It's like Coke and Pepsi.
Hold on,
Memorial
Google
Herman?
for you.
I'm pretty sure it's life flight out of Albany.
I don't think that's.
Greg.
Albany, New York, life flight.
Thank you. What do I know?
You sure? Because did you check the actual hospital name there? Memorial Herman? That's who they're associated with.
Oh, whatever. There's a life flight in Albany.
There's a life flight in Maine too.
All right. So clinical reasons to call. Patients in shock. We're going to go over during pathophysiology, medical assessment, trauma, what shock is. Just know that if a patient's in shock, that could be a good reason to call for air rescue. GCS of less than 10. Again, situation dependent. If I'm 10 minutes from the closest hospital, I'm not going to call for a helicopter when I can get that patient to the hospital in 10 minutes, right? Use your common sense, use your experience when you're calling for that. Head injury or altered mental status, that's a good one. So any significant trauma, our closest level 1 trauma center is down in EMS. So if I'm out in Sheldon or Montgomery or Bakersfield, that's a good example for that patient because they have a trauma team there that can care for them. Again, those are all trauma reasons to call. Amputations, extensive burns, serious mechanisms of injury, or patients post-cardiac arrest with a pulse. So a lot of air rescue is focused around trauma. Post-cardiac arrest is a good reason to use them. Even some strokes, with airway complications, that would be a good reason to use them. But again, that's kind of dependent if you're in a remote location versus 10 minutes from the hospital. So again, kind of use your common sense with that. So how to call for air rescue. So with us, we call our central dispatch. So we call central dispatch or radio them over the radio and say, hey, is medical center, yeah.
Houston.
Is that one out of Houston?
That's Houston.
Alright, just over life flight. So for around here, if we want to call for a helicopter, we call central dispatch and we say, hey, is UVM life flight, is the UVM helicopter available? They'll either tell us yes or no. If they're not available, then we say, all right, is Dartmouth available? Is life flight out of Albany available? You've got multiple options.
Even life flight of Maine.
Life flight of Maine.
We're actually still within their flight
They
capacity.
base their distance of coverage based on fuel capacity. So if they have the fuel capacity to make it to us and make it to the hospital, then they'll come to us.
Do you use, so there's the one out of Albany, but there's 2 other services in the Adirondacks.
Yeah, there's
Yep.
LifeNet in Ticonderoga. They have a bird there, and I've never used them. We could call for them, but we've just never used them,
We used
especially
them
with
last year in Enosburg,
Yep.
yeah.
Oh, yep.
Yep.
Ticonderoga?
Ticonderoga.
Yep.
Yeah.
I didn't know this. Actually, Ticonderoga is closer to us than Dartmouth is
Yes.
Yeah,
for flight.
and that's for
But
the
when HealthNet's available,
utility
they're
truck
obviously
Right.
the best and closest. So
Yeah.
We actually loaded the patient with the rotors going.
Oh,
It was
really?
really sketchy.
Yeah, that's
Well, that-
terrifying.
I didn't realize that there was like different types of ambulances, different types of helicopters. This one had the stretcher attached to the door.
Yeah, the
Really?
stretcher,
Very
their
good.
stretcher
I've never seen one
didn't
like
come
that.
out, so we brought our stretcher over, took the patient on a backboard, put it on their stretcher, and it pivoted in.
But while
it's
the
kind of
motors are going,
similar to Life Flight of Maine. They had a section of their stretcher didn't come out, but they had like an airframe that would come out sideways and go onto our stretcher.
Oh,
So
weird.
you'd load them in feet first, and then it would slide over and lock in.
Yeah,
Because they had a side loading helicopter
Yeah,
instead of
Dartmouth
rear.
and UVM is rear loading,
yeah.
which is
Hard to do
also kind of sketchy because you've got a rear rotor.
Well, that's why they don't do hot loads.
Right.
Yeah,
Whereas a
those
side
are
loader,
really-
you can hot load a patient.
Yeah, but as soon as we moved that backboard and the sheet just started floating up towards the
Yeah, that's
rotor.
sketchy.
Yeah.
If anything touches the rotors, it has to be completely.
Oh, yeah. I grabbed that
So-
sheet and I started bundling it up. I was like,
That's a
"Holy
good
shit."
point. Can you, if rotors are on and they're actively spinning, can you see them?
Nope.
No, you can't. So
You can feel it.
always go, always go by the flight crew. The flight crew will direct you where to approach the helicopter, especially if the rotors are going.
Pay attention to the pilot.
Yeah, exactly. Don't just run up to that helicopter with the patient because you don't want to get thwacked by a rotor. You won't live. So go by your flight crew, and we actually talk about that a little bit in here. So we call dispatch, we tell them, you know, we need a helicopter to this area. Fire usually is good about setting up a landing zone for us. They know the terrain a little bit better for us. We may not have that availability because it's very weather dependent and terrain dependent. If we don't have appropriate terrain for them to land, or there's a cloud out, sometimes that happens, they won't fly. They come up with whatever reason not to fly.
They give you just a few minutes too. They know right away.
Yep, exactly.
I've landed Dart in the middle of the woods on an old logging landing.
Mm-hmm.
That was interesting.
Yeah. Do what you gotta do. Another thing about this that I will say, if you're dispatching a call that sounds really bad and you're out in the middle of nowhere, it is
Yeah,
fine
boy.
to call dispatch right away and say, hey, can you get them up in the air and I'll let you know if I need them. They will hover the landing pad and wait for your call. They're fine with that. That is totally okay.
They love to fly.
So
They'll actually probably fly towards you.
Yeah,
Because they'll just use it as a training. If you
Yep.
end up canceling,
Yep.
they just count it as hours.
Yep.
So
exactly.
Nothing. The bill doesn't start till they
So
touch
they're
the
there.
patient.
Until they
Yeah.
transport.
Exactly. So it never hurts. Like, hey, we're headed to this area, and can you have Dartmouth hover the pad? And we'll advise further. You're okay to do that. We touched all that. Obtain GPS coordinates if you need to set up a landing zone.
typically fire will handle that side of things.
Because we're dealing with a patient. Describe the landing zone to the air rescue service, the type of terrain, landing in a field, landing on the road, whatever. Major landmarks, estimated distance to nearest town, other pertinent information such as hanging wires or ditches, wind, if you're able to determine the wind speed. So a landing zone. So caution, loading, and exit path. So again, if the rotors are moving where you approach the helicopter, appropriate landing zone needs to be marked off 100 feet in each direction. So if there's anything inside that 100 feet, that is not a good landing zone. So that includes telephone wires, buildings, towers, whatever. It has to be a 100-foot area clear for them to land. Oops. Okay. So areas to approach the helicopter. Again, don't go by this picture as the end-all be-all. Go by the flight crew. Different helicopters, they will advise you to approach from different areas. Rear-loading helicopters, they will advise you to approach from the rear, not the front. And that's all because of how they're pitching their rotors. So if they're pitching their rotors forward, that means it could be at head level and you could get hit. So wait for your flight crew to tell you where to approach the helicopter. Yeah, and a big thing on here, the tail rotor. Most tail rotors are in that encompassed little area, so there's no risk. Some helicopters don't have that encompassed tail rotor. Keep that in mind. You can't see a spinning rotor. So do not approach unless escorted by a flight personnel. Allow the crew to direct loading of the patient. Stay clear of the tail rotor at all times. Keep traffic and vehicles at least 100 feet from the helicopter. Don't smoke near the, I don't know why you would ever smoke near the aircraft. You're just going to rip a heater while you're loading the, I don't know.
I think of one person that would.
Yeah, I can too.
And that's why they have the warning.
Yeah, exactly. So, no smoking near the aircraft, no smoking inside your ambulance. There's oxygen. Be aware of danger areas, so terrain, particular hazards. And that's it. I kind of cruised through that. Any questions on that? That's the nitty gritty of this. Next week we start on AMP. So AMP is a big chapter. Joe and I are going to split that chapter. Be prepared. There's a lot to remember in that.
A lot of important stuff.
Yeah.
That's fun. That's better than like